Hematology and Oncology Audiobook, for USMLE Step 1, Listen and Think. Are you fucking ready? Let's talk about hematology and oncology, and more specifically, embryology. The fetal erythropoiesis occurs in the yolk sac from 3 to 8 weeks, the liver from 6 weeks to birth, the spleen from 10 to 28 weeks, and the bone marrow from 18 weeks to adult. And to help you remember this, you could remember it with mnemonic that the young liver synthesizes blood. Listen carefully. Hemoglobin development begins early, and embryonic globins include zeta and epsilon, while fetal hemoglobin, also known as HbF, is composed of alpha-2 and gamma-2, and as the fetus matures, adult hemoglobin, which is called HbA1, and consists of alpha-2 and beta-2, gradually takes over, while HbA2, made of alpha-2 and delta-2, is another form of adult hemoglobin that is present in small amounts. Now let's talk about oxygen affinity, because HbF has a higher affinity for O2, and the reason is, it binds to 2,3-BPG with relatively lower affinity, and this unique property enables HbF to effectively capture oxygen from maternal hemoglobin, including both HbA1 and HbA2, across the placenta, which is essential for fetal oxygenation. And this physiologic adaptation ensures that the fetus receives adequate oxygen supply from the maternal circulation, which is crucial for survival and growth. You should remember this: from fetal to adult hemoglobin, alpha always, gamma goes, becomes beta, and this simple mnemonic highlights a key concept in the switching of globin chains during development, where the gamma globin genes are downregulated after birth, and beta globin genes are upregulated to form adult hemoglobin. The ABO classification of blood groups, encompassing groups A, B, AB, and O, is defined by the presence of specific antigens on RBC surfaces, with Group A displaying A antigens, Group B displaying B antigens, Group AB displaying both A and B antigens, and Group O displaying no antigens, while the antibodies in plasma correspond inversely, as Group A possesses anti-B antibodies, Group B possesses anti-A antibodies, Group AB has no antibodies, and Group O has both anti-A and anti-B antibodies. Compatible RBC types to receive being A and O for Group A, and B and O for Group B, but we can use AB, A, B, and O for Group AB, and only O for Group O. And compatible types to donate to being A and AB for Group A, and B and AB for Group B, only AB for Group AB, and all groups, A, B, AB, O, for Group O. The Rh classification, centered on the presence or absence of the Rh, D, antigen, distinguishes Rh-positive individuals, who have the D antigen, from Rh-negative individuals, who lack it, with Rh-negative plasma containing anti-D antibodies only after prior exposure to Rh-positive blood, while Rh-positive plasma lacks these antibodies. And compatible RBC types to receive for Rh-negative individuals are exclusively Rh-negative, whereas Rh-positive individuals can receive both Rh-positive and Rh-negative blood, with donation compatibility allowing Rh-negative individuals to donate to both Rh-positive and Rh-negative recipients, and Rh-positive individuals limited to donating to Rh-positive recipients. The clinical relevance of these blood group systems is prominently observed in hemolytic disease of the fetus and newborn, also termed erythroblastosis fetalis, which is a condition most frequently arising from incompatibilities in the major blood group antigens, such as Rh and ABO, though minor blood group disparities, like KEL, can also contribute to disease manifestations ranging from mild to severe. ABO hemolytic disease, typically occurring in type O pregnant patients carrying a type A or B fetus, involves pre-existing maternal anti-A or anti-B IgG antibodies crossing the placenta, leading to fetal and newborn RBC hemolysis, which presents as mild jaundice within the first 24 hours of birth, distinct from Rh hemolytic disease in its ability to affect firstborn infants and generally milder course, with treatment involving phototherapy or exchange transfusion. In contrast, Rh hemolytic disease arises when an Rh-negative pregnant patient carries an Rh-positive fetus, with sensitization during the first pregnancy, often at delivery, triggering maternal anti-D IgG production, which in subsequent pregnancies crosses the placenta, causing severe hemolysis manifesting as hydrops fetalis, early onset jaundice, or kernicterus. A condition preventable through the administration of anti-DIgG to Rh-negative pregnant patients during the third trimester. Postpartum, and in cases of ectopic pregnancy, miscarriage, abdominal trauma, or antepartum hemorrhage, thereby inhibiting maternal antibody formation and safeguarding future pregnancies. Hematopoiesis, where everything begins from a multipotent stem cell that branches into myeloid and lymphoid stem cells, continuing from there to form the diverse blood components. Myeloid stem cells give rise to myeloblasts, monoblasts, erythroblasts, and megakaryoplasts, leading to granulocytopoiesis, monocytopoiesis, erythropoiesis, and thrombopoiesis, respectively. Meanwhile, lymphoid stem cells produce lymphoblasts that differentiate into B cells, T cells, and NK cells, with B cells transforming into plasma cells, and T cells branching into T helper and T cytotoxic cells. Now shifting our focus to neutrophils, let's explore their role more deeply, as these are acute inflammatory response cells that are phagocytic, with multilobed nuclei, and specific granules that contain leukocyte alkaline phosphatase, collagenase, lysozyme, and lactoferrin. In addition, they possess azurophilic granules, or lysosomes, which are filled with proteinases, acid phosphatase, myeloperoxidase, and beta-glucuronidase. During inflammatory states, such as bacterial infections, you will notice neutrophilia, and distinct changes in neutrophil morphology, like a left shift, toxic granulation, which appears as dark blue and coarse granules, and the presence of dull bodies, seen as light blue, peripheral inclusions. There may also be cytoplasmic vacuoles. There are several chemotactic agents draw neutrophils to sites of infection, including C5a, IL-8, LTB4, 5-HEAT which is a leukotriene precursor, as well as kallikrein, platelet-activating factor, and bacterial proteins such as N-formylmethionine. And remember, hypersegmented neutrophils, whose nuclei contain 5 to 6 or more lobes, are found in vitamin B12 or folate deficiency, and when we speak of a left shift, we refer to increased neutrophil precursors in peripheral blood, such as band cells and metamyelocytes, reflecting a rise in myeloid proliferation as seen in inflammation or chronic myeloid leukemia. Now finally, let's highlight a leukoerythroblastic reaction, which is a left shift that is accompanied by immature red blood cells, and this pattern strongly suggests bone marrow infiltration, which may occur in conditions like myelofibrosis or metastasis. Now let's begin with erythrocytes, which are essential cells that carry oxygen to tissues and carbon dioxide to the lungs, and importantly, they are anucleate and lack organelles. These cells are biconcave in shape, and this structure provides a large surface area to volume ratio, which facilitates rapid gas exchange across their membranes. In healthy adults, erythrocytes have a lifespan of approximately 120 days, while in neonates, this duration shortens to about 60 to 90 days. Their energy source is glucose, where 90% is used in glycolysis, and the remaining 10% goes into the HMP shunt. Their membranes contain a chloride bicarbonate antiporter, which allows them to export bicarbonate and carry carbon dioxide from the periphery to the lungs, where it can be eliminated. The term erythro means red, and cyte means cell. Now listen carefully motherfuckers, erythrocytosis, which is also called polycythemia, refers to an increase in hematocrit, while anisocytosis indicates varying sizes among red blood cells, and poikilocytosis means varying shapes. A respiratory, which is an immature red blood cell, reflects active erythroid proliferation, and on a right Giemsa stain, these reticulocytes show a bluish color, known as polychromasia, which represents the presence of residual ribosomal RNA. Transitioning smoothly, let's explore thrombocytes, also known as platelets, which play a crucial role in primary hemostasis. They are small cytoplasmic fragments, derived from megakaryocytes, and they are anucleate. Their lifespan typically ranges from 8 to 10 days, often remembered by the phrase, PL8lets. When endothelial injury occurs, these platelets become activated, aggregate with one another, and interact with fibrinogen to form a platelet plug. They contain dense granules that store calcium, ADP, serotonin, and histamine, abbreviated as CASH, and they also have alpha granules that hold VWF, fibrinogen, fibronectin, and platelet factor 4. It is worth noting that about 1/3 of the total platelet pool is stored in the spleen. Follow closely, a reduction in platelet count or function, which includes thrombocytopenia, often leads to the appearance of petechiae. The receptor for VWF on platelets is GPIB, while the receptor for fibrinogen is GP2B/3A. Thrombopoietin is the growth factor that stimulates megakaryocyte proliferation, and alpha granules that contain VWF, fibrinogen, fibronectin, and platelet factor 4, all of which contribute to clot formation and vascular repair. Shifting to monocytes, these are found circulating in the blood and later differentiate into macrophages or dendritic cells once they reach tissues. Monocytes have a large, kidney-shaped nucleus, and their cytoplasm has an extensive, frosted glass appearance. The prefix mono means one, referring to the single nucleus, and cyte again means cell. These monocytes are key components of the immune system, ready to respond when needed. And now, let's dive into macrophages, which are a type of antigen-presenting cell. They phagocytose bacteria, cellular debris, and senescent red blood cells, and they have a long lifespan once they settle into tissues. They differentiate from circulating blood monocytes, and are activated by interferon gamma, or IFN gamma. These cells can also present antigens via MHC class II molecules and are involved in antibody-dependent cellular cytotoxicity. They are important players in the formation of granulomas, such as those seen in tuberculosis or sarcoidosis, where they may fuse together and form large, multinucleated giant cells. Finally, you should remember, the naming of macrophages varies depending on the specific tissue type in which they reside. For instance, in the liver, they are called Kupffer cells, in connective tissue, they are known as histiocytes, in bone, they become osteoclasts, and in the brain, they are referred to as microglial cells. Moreover, the lipid A component of bacterial lipopolysaccharide, or LPS, binds to CD14 on macrophages, triggering the cascade that leads to septic shock. Now listen carefully, dendritic cells are highly phagocytic antigen-presenting cells, and they function as a critical link between the innate and adaptive immune systems, for example, by stimulating T cells. These cells express MHC class II and Fc receptors on their surface, and interestingly, they also have the unique ability to present exogenous antigens on MHC class I molecules, through a process known as cross-presentation. Let's talk about the fucking eosinophils, which defend the body against helminthic infections using a weapon called major basic protein. They have a distinctive bilobate nucleus and are packed with large eosinophilic granules that are uniform in size. These cells are highly phagocytic for antigen-antibody complexes, and they produce substances like histaminase, major basic protein or MBP, which is a helminthotoxin, eosinophil cationic protein, eosinophil-derived neurotoxin, and interleukin-5 or IL-5, which promotes their activation and proliferation. You should remember this, eosin means pink dye, and philic means loving, so eosinophilic literally means loving pink. The causes of eosinophilia, also remembered with the mnemonic Pac-Man eats, include parasites, asthma, chronic adrenal insufficiency, myeloproliferative disorders, allergic processes, neoplasia such as Hodgkin lymphoma, and eosinophilic granulomatosis with polyangiitis. Moving on to basophils, these cells mediate allergic reactions, and their densely basophilic granules contain both heparin, which acts as an anticoagulant, and histamine, which is a vasodilator. They also synthesize and release leukotrienes on demand. The term basophilic means they stain readily with basic stains, and while basophilia is uncommon, it can be an important sign of myeloproliferative disorders, particularly chronic myelogenous leukemia, abbreviated as CML. Have you heard about mast cells? Which mediate local tissue allergic reactions and contain basophilic granules. They originate from the same precursor as basophils, but they are not the same type of cell. Mast cells can bind the Fc portion of IgA to their membrane and are activated by tissue trauma, by complement components C3a and C5a, and by surface IgA cross-linking through antigen, which leads to IgA receptor aggregation. This results in degranulation and the release of histamine, heparin, tryptase, and eosinophil chemotactic factors. These cells are involved in type 1 hypersensitivity reactions, and chromalin sodium is a drug that prevents mast cell degranulation, and is used for asthma prophylaxis. You should remember this too: vancomycin, opioids, and radiocontrast dye can trigger mast cell degranulation even without involving IgA. Mastocytosis, although rare, involves the proliferation of mast cells in the skin and sometimes in extracutaneous organs, and it is associated with CKIT mutations and elevated serum tryptase. Increased histamine levels in this condition can lead to flushing, pruritus, hypotension, abdominal pain, diarrhea, and even peptic ulcer disease. Now listen carefully: lymphocytes refer to B cells, T cells, and natural killer or NK cells. Among these, B cells and T cells are responsible for mediating the adaptive immune response, while NK cells play a role in the innate immune response. These lymphocytes characteristically have a round, densely staining nucleus, and only a small amount of pale cytoplasm surrounding it. Now let's talk more specifically about natural killer cells, often marked by CD56 and CD16, also called Fc receptors. NK cells are important players in innate immunity, especially in the fight against intracellular pathogens. They are larger than both B and T cells and contain distinctive cytoplasmic lytic granules that are packed with perforin and granzymes. When released, these granules act on target cells to induce apoptosis. Are you following me? NK cells distinguish healthy cells from infected ones by recognizing changes in cell surface proteins, which can be altered due to stress, malignant transformation, or microbial infections. They are particularly effective at inducing apoptosis in cells that do not express MHC class I molecules, such as virally infected cells in which these molecules are often downregulated. Now moving on to B cells, which mediate the humoral immune response. They originate from stem cells in the bone marrow, and unlike T cells, they also mature in the bone marrow. After maturation, they migrate to peripheral lymphoid tissue, including follicles of lymph nodes, white pulp of the spleen, and unencapsulated lymphoid tissues. When they encounter an antigen, B cells differentiate into plasma cells, which produce antibodies, and memory cells, which help in future immune responses. B cells can also act as antigen-presenting cells. You should remember this: B is for bone marrow. Key surface markers include CD19, CD20, and CD21. Now let's focus on T cells, which mediate the cellular immune response. These cells also originate from bone marrow stem cells, but they mature in the thymus. Once mature, they differentiate into various types: cytotoxic T cells that express CD8 and recognize MHC class I molecules, helper T cells that express CD4 and recognize MHC class II molecules, and regulatory T cells that help modulate immune responses. CD28 is a critical costimulatory signal required for proper T cell activation. It's important to know that most circulating lymphocytes, about 80%, are actually T cells. And yes, T stands for thymus. You should also remember that CD4 plus helper T cells are the primary target of HIV. Cytotoxic T cells carry CD8 and CD3, while helper T cells express CD4 and CD3. A helpful rule to keep in mind is the rule of 8, MHC 2 times CD4 equals 8, and MHC 1 times CD8 also equals 8. And finally, let's talk about plasma cells. These cells are the antibody factories of the immune system, producing large amounts of antibodies specific to a particular antigen. They have a characteristic clock face chromatin distribution, an eccentric nucleus, abundant rough endoplasmic reticulum or RR, and a well-developed Golgi apparatus. These features make them easy to recognize under the microscope. Plasma cells are found in the bone marrow and, under normal conditions, do not circulate in peripheral blood. You should remember that multiple myeloma is a type of plasma cell dyscrasia. Now listen carefully: lymphocytes refer to B cells, T cells, and natural killer or NK cells. Among these, B cells and T cells are responsible for mediating the adaptive immune response, while NK cells play a role in the innate immune response. These lymphocytes characteristically have a round, densely staining nucleus, and only a small amount of pale cytoplasm surrounding it. Now let's talk more specifically about natural killer cells, often marked by CD56 and CD16, also called FC receptors. NK cells are important players in innate immunity, especially in the fight against intracellular pathogens. They are larger than both B and T cells and contain distinctive cytoplasmic lytic granules that are packed with perforin and granzymes. When released, these granules act on target cells to induce apoptosis. Are you following me? NK cells distinguish healthy cells from infected ones by recognizing changes in cell surface proteins, which can be altered due to stress, malignant transformation, or microbial infections. They are particularly effective at inducing apoptosis in cells that do not express MHC class I molecules, such as virally infected cells in which these molecules are often downregulated. Now moving on to B cells, which mediate the humoral immune response. They originate from stem cells in the bone marrow, and unlike T cells, they also mature in the bone marrow. After maturation, they migrate to peripheral lymphoid tissue, including follicles of lymph nodes, white pulp of the spleen, and unencapsulated lymphoid tissues. When they encounter an antigen, B cells differentiate into plasma cells, which produce antibodies, and memory cells, which help in future immune responses. B cells can also act as antigen-presenting cells. You should remember this. B is for bone marrow. Key surface markers include CD19, CD20, and CD21. Now let's focus on T cells, which mediate the cellular immune response. These cells also originate from bone marrow stem cells, but they mature in the thymus. Once mature, they differentiate into various types: cytotoxic T cells that express CD8 and recognize MHC class I molecules, helper T cells that express CD4 and recognize MHC class II molecules, and regulatory T cells that help modulate immune responses. CD28 is a critical costimulatory signal required for proper T cell activation. It's important to know that most circulating lymphocytes, about 80%, are actually T cells. And yes, T stands for thymus. You should also remember that CD4 plus helper T cells are the primary target of HIV. Cytotoxic T cells carry CD8 and CD3, while helper T cells express CD4 and CD3. A helpful rule to keep in mind is the rule of 8, MHC 2 times CD4 equals 8, and MHC 1 times CD8 also equals 8. And finally, let's talk about plasma cells. These cells are the antibody factories of the immune system, producing large amounts of antibodies specific to a particular antigen. They have a characteristic, clock face, chromatin distribution, an eccentric nucleus, abundant rough endoplasmic reticulum or RR, and a well-developed Golgi apparatus. These features make them easy to recognize under the microscope. Plasma cells are found in the bone marrow and, under normal conditions, do not circulate in peripheral blood. You should remember that multiple myeloma is a type of plasma cell dyscrasia. Now listen carefully. Hemoglobin electrophoresis is a laboratory method used to separate different types of hemoglobin based on their movement in an electric field, from the negatively charged cathode to the positively charged anode. In this process, HbA, which is normal adult hemoglobin with a beta chain, migrates the farthest, followed by HbF, the fetal hemoglobin containing an alpha chain, then HbS, the sickle cell hemoglobin with a mutated beta chain, and finally HbC, which contains the hemoglobin C beta chain. The reason for this order lies in the electrical charges of the amino acid substitutions. HbS has a missense mutation that replaces glutamic acid, which carries a negative charge, with valine, which is neutral. HbC replaces glutamic acid with lysine, which carries a positive charge. So, compared to HbA, both HbS and HbC become more positively charged and thus migrate more slowly. And here's a helpful mnemonic for you: a fat Santa Claus can't go far, meaning HbC stays closest to the cathode, while HbA travels closest to the anode. Now let's take a moment to review the hemoglobin patterns you might see in different conditions. In normal adults, the pattern is AA. In normal newborns, it's AF. For sickle cell trait, the result is AS. In full sickle cell disease, it's SS. In hemoglobin C trait, the pattern is AC. For hemoglobin C disease, it is CC. And in hemoglobin SC disease, the pattern shows both S and C, which you might see as SC or SFA, depending on the method. Each of these reflects a specific combination of normal and abnormal hemoglobin chains. Now let's move to the antiglobulin test, which is also known as the Coombs test. This test detects the presence of antibodies against circulating red blood cells. There are two types, direct and indirect. In the direct antiglobulin test, also called the direct Coombs test, antihuman globulin, which is the Coombs reagent, is added directly to the patient's red blood cells. If the red cells are coated with anti-RBC antibodies, they will agglutinate. This version of the test is used for diagnosing autoimmune hemolytic anemia, also called AIHA. Are you following me? The indirect antiglobulin test, also known as the indirect Coombs test, works a little differently. Here, normal red blood cells are added to the patient's serum. If the serum contains anti-red blood cell antibodies, those normal red cells will agglutinate when Coombs reagent is added. This test is not for diagnosis of AIHA, but rather used for pre-transfusion testing, to see whether the recipient might react against donor red blood cells. Now let's summarize what these results mean. If you perform the direct antiglobulin test and see agglutination, it indicates the presence of anti-red blood cell antibodies, and therefore, supports a diagnosis of autoimmune hemolytic anemia. If there's no agglutination, it means those antibodies are absent, and AIHA is unlikely. Similarly, for the indirect test, if there is agglutination, it shows the patient's serum contains antibodies that could react with donor red blood cells, suggesting a possible transfusion reaction. But if no agglutination occurs, it means those antibodies are absent, and the transfusion should be safe. You should remember this process well. When performing the indirect Coombs test, you mix patient serum, which may or may not contain anti-red blood cell antibodies, with donor blood and antihuman globulin. For the direct test, you mix the patient's red blood cells, which may or may not be coated with antibodies, with antihuman globulin reagent. A positive result means agglutination and the presence of anti-RBC antibodies, while a negative result means no agglutination and no antibodies. Now let's talk about platelet plug formation, also called primary hemostasis. This process creates a temporary plug that stops bleeding, but keep in mind, it's unstable and easily dislodged. The first step is injury, which leads to exposure of the subendothelial collagen. Then comes adhesion, followed by activation, and finally, aggregation. At the site of endothelial damage, transient vasoconstriction occurs, triggered by a neural stimulation reflex and the release of endothelin from the damaged cells. In this early stage, von Willebrand factor, or VWF, binds to exposed collagen. VWF is released from the Weibel-Palade bodies of endothelial cells and from the alpha granules of platelets. Now listen carefully. Platelets bind to VWF through the GP1B receptor at the site of injury, and this interaction is very specific. Once this happens, platelets undergo a conformational change. Then comes activation, where platelets release ADP, calcium ions which are essential for the coagulation cascade, and thromboxane A2, also known as TXA2. ADP, binding to the P2Y12 receptor, induces the expression of GP2B/3A on the surface of the platelets, which leads to rapid, irreversible platelet aggregation. Let's shift to the aggregation phase, where fibrinogen binds to the GP2B/3IA receptors and serves as a bridge between platelets, linking them together. This entire sequence is finely balanced between anti-aggregation and pro-aggregation forces. On one side, anti-aggregation factors like prostacyclin, or PGI2, and nitric oxide, or NO, are released by endothelial cells. These agents increase blood flow and reduce platelet aggregation. On the other side, pro-aggregation forces like TXA2 are released by platelets. TXA2 decreases blood flow and increases platelet aggregation. Are you following me? This sets the stage for secondary hemostasis, or the coagulation cascade, which stabilizes the plug by forming an insoluble fibrin mesh. This is called thrombogenesis. Drugs can affect this process in various ways. Aspirin, for instance, irreversibly inhibits cyclooxygenase, or COX, thereby blocking TXA2 synthesis. Clopidogrel, prasugrel, and ticagrelor work by inhibiting ADP-induced expression of GP2B/3A, specifically by blocking the P2Y12 receptor. Other agents like eptifibatide and tirofiban directly inhibit GP2B/3A, which is the fibrinogen receptor. Let's talk about diagnostic tests. Ristocetin is a special agent that activates VWF to bind GP1B. When aggregation fails in a ristocetin assay, it suggests von Willebrand disease or Bernard-Soulier syndrome. And remember, desmopressin promotes the release of VWF and factor VIII from endothelial cells. It's important to know that VWF not only mediates platelet adhesion but also carries and protects factor VIII. And here's a clever mnemonic: Volkswagen factories make GR8 cars, meaning VWF is linked to factor VIII. Listen carefully as we name key deficiencies. A deficiency in VWF results in von Willebrand disease. A deficiency in GPIB leads to Bernard-Soulier syndrome. And a deficiency in GP2B/3A leads to Glanzmann thrombasthenia. The major players to remember here include the ADP-P2Y12 receptor, the GPIB receptor that binds VWF, and the GP2B/3A receptor that binds fibrinogen. The drugs clopidogrel, prasugrel, and ticagrelor target the P2Y12 receptor, while eptifibatide and tirofiban block GP2B/3IA directly. Aspirin blocks TXA2, while desmopressin boosts VWF and factor VIII. Now listen carefully as we begin with the coagulation and kinin pathways. PT, or prothrombin time, monitors the extrinsic and common pathways, and it reflects the activity of factors 1, 2, 5, 7, and 10. Meanwhile, PTT, or partial thromboplastin time, monitors the intrinsic and common pathways, and it reflects the activity of all factors, except factor 7 and factor 13. Let's break it down by pathways. First, the extrinsic pathway, also called the tissue factor pathway, is triggered when damage to blood vessels releases tissue factor, or TF, from subendothelial cells. TF binds to factor 7, activating it to 7A, and this requires calcium. The TF7A complex then directly activates factor 10, entering the common pathway, and it also activates small amounts of factor 9, linking the extrinsic and intrinsic pathways together. Now let's talk about the key features of the extrinsic pathway. It acts fast, within seconds to minutes, and it is measured by prothrombin time, or PT, in laboratories. One important note is that factor 7 is vitamin K dependent, which means it needs vitamin K for synthesis. Now we shift to the intrinsic pathway, also called the contact activation pathway. It is triggered by exposure to negatively charged surfaces, like collagen or activated platelets. In this process, factor 12 becomes 12A when it contacts collagen or kallikrein. Then 12AA activates factor 11 to 11A, which in turn activates factor 9 to 9A. Factor 9A, together with cofactor 8A, calcium, and phospholipids, goes on to activate factor 10. Are you following me? The intrinsic pathway is slower than the extrinsic one, taking minutes, and it is measured by activated partial thromboplastin time, or APTT. Deficiencies in this pathway cause various hemophilias. Hemophilia A involves factor 8 and leads to prolonged APTT. Hemophilia B involves factor 9 and also prolongs APTT. Hemophilia C involves factor 11, causes milder bleeding, and is inherited in an autosomal recessive pattern. Don't forget, kallikrein and high molecular weight kininogen, or HMWK, amplify this intrinsic pathway. Now we move to the common pathway, the the convergence point where both intrinsic and extrinsic routes activate factor 10 into 10A. 10A then joins with cofactor 5A, calcium, and phospholipids to form the prothrombinase complex. Now listen carefully, this complex converts prothrombin, which is factor 2, into thrombin, also called 2A. Thrombin has multiple crucial roles. It converts fibrinogen into fibrin monomers, and it activates factor 13 into 13A, which cross-links fibrin into a stable mesh. Thrombin also feeds back to amplify clotting, by activating factors 5, 8, 11, and platelets. Key points to remember here: deficiencies in factors 10, 5, 2, or fibrinogen affect both PT and APTT, because they lie in the common pathway. The vitamin K-dependent factors are 2, 7, 9 and 10, this is important in both clinical practice and pharmacology. Now let's talk about how coagulation is regulated. Antithrombin, or AT, neutralizes thrombin and 10A, and its activity is enhanced by heparin or low molecular weight heparin, LMWH. Protein C and protein S inactivate factors 5A and 8A, and both require vitamin K. Tissue factor pathway inhibitor, or TFPI, inhibits the TF7AA complex and factor 10A. Fibrinolysis begins when plasmin, which comes from plasminogen, breaks down fibrin. Drugs like alteplase enhance this process by boosting plasmin formation. Now listen carefully to the clinical disorders and their relevance. Hereditary angioedema involves a deficiency of C1 inhibitor, which causes excess kallikrein and unregulated bradykinin production, leading to swelling. Vitamin K deficiency affects synthesis of factors 2, 7, 9 and 10, causing prolonged PT and APTT. D-dimer becomes elevated when clots are being broken down, such as in cases of deep vein thrombosis, or DVT, and pulmonary embolism, or PE. Now we transition to pharmacologic agents. Anticoagulants like heparin and LMWH enhance antithrombin to inhibit factor 10A and thrombin. Direct 10A inhibitors, like apixaban, block factor 10A directly. Direct thrombin inhibitors, such as dabigatran, target thrombin itself. Now let's finish with antifibrinolytics like tranexamic acid, which prevent plasmin from dissolving clots. From a modern perspective, we now view coagulation not just as a cascade, but as a cell-based model consisting of overlapping phases. In the initiation phase, TF7AA activates small amounts of 10A and thrombin. During amplification, thrombin activates cofactors and primes platelets. And in the propagation phase, a large thrombin burst stabilizes the clot. This finely tuned system balances clot formation and breakdown. When it's disrupted, bleeding disorders like hemophilia or thrombotic conditions like DVT may result. Now let's talk about vitamin K-dependent coagulation. In procoagulation, vitamin K deficiency reduces gamma carboxylation and maturation of several critical factors, specifically factors 2, 7, 9, 10, and also protein C and protein S. Warfarin acts by inhibiting vitamin K epoxide reductase, which interferes with this carboxylation process. When vitamin K is administered, it can potentially reverse warfarin's inhibitory effect on clotting factor synthesis, although this reversal is delayed. For immediate reversal, fresh frozen plasma, abbreviated as FFP, or prothrombin complex concentrate, or PCC, can be administered, and these are often given together with vitamin K in cases of severe bleeding. Now listen carefully, because this is important in neonates. Newborns lack enteric bacteria, and those bacteria are responsible for producing vitamin K. So early administration of vitamin K is essential. It overcomes the natural neonatal deficiency and prevents coagulopathy. Broad-spectrum antibiotics also suppress gut flora, and this can lead to vitamin K deficiency in adults. Among the vitamin K-dependent factors, factor 7 has the shortest half-life, while factor 2, also called prothrombin, has the longest, too long, in fact, for rapid changes. Now we move to anticoagulation. Antithrombin inhibits multiple factors. It targets thrombin, which is factor 2A, and also factors 7A, 9A, 10A, 11A, and 12A. Heparin enhances the activity of antithrombin, making it a powerful anticoagulant. But the principal targets of antithrombin are thrombin, or factor 2A, and factor 10A. Now listen closely, there's also the factor V Leiden mutation, and this produces a form of factor V that is resistant to inhibition by activated protein C. Clinically, tissue plasminogen activator, or TPA, is used as a thrombolytic agent, and it helps dissolve clots. Now are you ready for the pathway mechanics? Reduced, or active, vitamin K enables gamma-glutamyl carboxylase, a vitamin K-dependent enzyme, to convert inactive clotting proteins, specifically factors 2, 7, 9, 10, and proteins C and S, into their mature, carboxylate forms. Warfarin disrupts this cycle by blocking epoxide reductase, preventing the regeneration of active vitamin K. In the liver, vitamin K moves between reduced, active, and oxidized, inactive forms during this process. Now listen carefully as we tie it all together. Factor 9A, with factor 8A as cofactor, activates factor 10. Factor 10A, with factor 5A as cofactor, converts prothrombin, factor 2, into thrombin, which is factor 2A. Thrombin then converts fibrinogen, which is factor 1, into fibrin, which is factor 1A. Meanwhile, activated protein C, with the help of its cofactor protein S, inactivates factors 5A and 8A, providing essential regulation. Heparin, low molecular weight heparin, and direct thrombin inhibitors all function to enhance antithrombin activity or directly inhibit thrombin. And finally, direct factor 10A inhibitors act at this critical junction to prevent clot propagation. We have reached our next subsection of hematology and oncology, which is pathology. Let's see red blood cell morphology. First, we have acanthocytes, also known as spur cells. These appear in liver disease, abetalipoproteinemia, and vitamin E deficiency. They have projections of varying sizes at irregular intervals, and you should remember this, acanthocytes are asymmetric, not uniform. Listen carefully, because next we have echinocytes, or Burr cells, which show up in liver disease, end-stage renal disease, and pyruvate kinase deficiency. Unlike acanthocytes, their projections are smaller, more uniform, and even, so just remember, echinocytes are even and echinocytes are Burr cells. Now let's move to dacrocytes, or teardrop cells. These are seen in bone marrow infiltration, such as myelofibrosis. The red blood cell sheds a tear, because it's been mechanically squeezed out of its home in the bone marrow, creating this distinctive shape. Next comes something dramatic, schistocytes, also called helmet cells. These are fragmented red blood cells, and they appear in microangiopathic hemolytic anemias, such as disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and HELLP syndrome, as well as mechanical hemolysis from heart valve prostheses. Now listen carefully, degmocytes, also known as bite cells, occur in glucose 6-phosphate dehydrogenase deficiency. This happens due to removal of Heinz bodies by splenic macrophages. They quite literally deg them out or bite them off the red blood cells. Are you ready for the next one? Elliptocytes appear in hereditary elliptocytosis, and this is caused by mutations in genes encoding red blood cell membrane proteins, like spectrin. These red blood cells are elliptical in shape, due to the structural defect. Now we arrive at spherocytes, which are found in hereditary spherocytosis and autoimmune hemolytic anemia. These cells are small, spherical, and lack central pallor. They have a reduced surface area to volume ratio, which is a key identifying feature. Next up are macroovulocytes, found in megaloblastic anemia, and often accompanied by hypersegmented polymorphonuclear cells, or PMNs. These are large, oval-shaped cells, classic signs of folate or B12 deficiency. Let's talk about a freaking target cells. They're seen in hemoglobin C disease, asplenia, liver disease, and thalassemia. Just remember the phrase, "Halt," said the hunter to his target. These cells have increased surface area to volume ratio, giving them their target-like appearance. Finally, we have sickle cells. These are present in sickle cell anemia, and sickling happens under low oxygen conditions, such as high altitude or acidosis, and especially when hemoglobin S concentration is high, like in dehydration. Their crescent shape is a hallmark of this condition. We shift gears to red blood cell inclusions. Starting with the bone marrow, we have iron granules, seen in sideroblastic anemias like lead poisoning, myelodysplastic syndromes, and chronic alcohol overuse. These granules form paranuclear rings in ringed sideroblasts, and to visualize them, you'll need a Prussian blue stain. Let's move to the peripheral smear now. Jolly bodies appear in functional hyposplenia, such as in sickle cell disease, or in asplenia. These are basophilic nuclear remnants that don't contain iron, and they are normally removed by splenic macrophages. Next, we see basophilic stippling, which occurs in sideroblastic anemias and thalassemias. These are basophilic ribosomal precipitates, and like jolly bodies, they also do not contain iron. Listen carefully, Pappenheimer bodies show up in sideroblastic anemias. These are basophilic granules that do contain iron, and a helpful way to remember them is to call them Pappenheimer bodies, because iron is heavy like a hammer. Finally, we have Heinz bodies, which are found in G6PD deficiency. These are denatured and precipitated hemoglobin inclusions that contain iron. The body removes them by forming bite cells, and that's why we say they take a bite of Heinz, like biting into ketchup. To visualize Heinz bodies, you'll need a supravital stain, such as crystal violet. Anemias are categorized based on red blood cell size, starting with microcytic types, where the MCV is below 80 FL. These often stem from hemoglobin issues, such as thalassemias due to defective globin chains. Other cause of microcytic anemia are from disrupted heme synthesis, seen in anemia of chronic disease, late-stage iron deficiency, and lead poisoning. Moving to normocytic anemias, with an MCV between 80 and 100 FL, these type may be hemolytic types, marked by a high respiratory index. Hemolytic anemias can also arise from intrinsic factors, such as membrane defects like hereditary spherocytosis or paroxysmal nocturnal hemoglobinuria, enzyme deficiencies such as G6PD or pyruvate kinase, or hemoglobinopathies like sickle cell anemia and HBC disease. Hemolytic anemia can also arise from extrinsic causes, which encompass autoimmune conditions, microangiopathic or macroangiopathic damage, and infections. Shifting to non-hemolytic causes, which show a low respiratory index, these include early iron deficiency, anemia of chronic disease, aplastic anemia, chronic kidney disease, and acute blood loss like hemorrhage are key contributors. Transitioning to macrocytic anemias, where MCV exceeds 100 FL, can be megaloblastic in which metabolic issues dominate, particularly defects in DNA synthesis, such as folate or vitamin B12 deficiencies, orotic aciduria, and DNA repair disorders like Fanconi anemia. Other type of macrocytic anemia are normegaloblastic causes, include Diamond-Blackfan anemia, liver disease, and chronic alcohol overuse. Let me tell you about the respiratory production index, which is also called the corrected respiratory count, and is used to correct falsely elevated respiratory values in anemia. It measures whether the bone marrow is responding appropriately to anemic conditions, which means it reflects effective erythropoiesis. When the RPI is high, more than 3, it shows there is a compensatory red blood cell production. But if the RPI is low, less than 2, that indicates an inadequate response to correct the anemia. Are you following me? The formula for calculating the RPI is, RPI equals the percent reticulocytes, multiplied by the ratio of actual hematocrit over normal hematocrit, and then divided by the maturation time. Now let's shift gears to something very important, the Menser index, which is used to differentiate between thalassemia trait and iron deficiency anemia. When the index is less than 13, that suggests thalassemia trait, but when it's greater than 13, it points toward iron deficiency anemia. The formula is very straightforward, listen carefully, it's the mean corpuscular volume, or MCV, divided by the red blood cell count, and that gives you the Menser index. Are you ready to talk about the interpretation of iron studies? In conditions like iron deficiency, chronic disease, hemochromatosis, or even during pregnancy or oral contraceptive use, we look at several parameters, including serum iron, transferrin or total iron binding capacity, TIBC, ferritin, and the percent transferrin saturation, which is calculated as serum iron divided by TIBC. So let's go step by step. In iron deficiency, serum iron goes down, transferrin or TIBC goes up, ferritin goes down, and transferrin saturation goes down as well. But pay attention, in anemia of chronic disease, serum iron goes down, transferrin also goes down or stays the same, ferritin goes up, and transferrin saturation may be normal or decreased. On the other hand, in hemochromatosis, serum iron goes up, TIBC goes down, ferritin goes up, and transferrin saturation goes way up. And in pregnancy or with oral contraceptive use, serum iron stays the same, TIBC goes up, ferritin is unchanged, and transferrin saturation may be reduced. Let's wrap this up with some key insights. Transferrin is the protein that transports iron in the blood, TIBC indirectly measures the level of transferrin, and ferritin is the body's primary iron storage protein. And now here's something fascinating. Evolutionary reasoning tells us that pathogens thrive on circulating iron, so the human body has developed a defense system that stores iron inside cells, preventing pathogens from accessing it in the bloodstream. Let's talk about microcytic, hypochromic anemias, where the mean corpuscular volume is less than 80 femtoliters. One major cause is iron deficiency, and this usually results from chronic bleeding, like from gastrointestinal loss or heavy menstrual bleeding, or it may arise from malnutrition, absorption disorders, or gastrointestinal surgery, such as a gastrectomy, and sometimes it's due to increased demand during pregnancy. All these conditions lead to a reduction in iron, which impairs the final step in heme synthesis. In lab studies, you'll find low iron, high total iron binding capacity, TIBC, low ferritin, increased free erythrocyte protoporphyrin, high red cell distribution width, RDW, and a reduced respiratory index. The blood smear may show microcytosis and hypochromasia, which means an increased central pallor. Listen carefully, symptoms of iron deficiency anemia include fatigue, conjunctival pallor, restless leg syndrome, pica, which is a persistent craving and compulsive eating of non-food substances, and spoon-shaped nails, also called cholonychia. It may also present with glossitis, chylosis, and even Plummer-Vinson syndrome, which is a triad consisting of iron deficiency anemia, esophageal webs, and dysphagia. Now let's move on to alpha thalassemia, which is caused by alpha-globin gene deletions on chromosome 16, resulting in decreased alpha-globin synthesis. These deletions may occur as cis deletions, meaning on the same chromosome, or trans deletions, meaning on different chromosomes. The normal genotype is alpha-alpha/alpha-alpha, and you should remember that in alpha thalassemia, the red blood cell count is often elevated, which is different from iron deficiency anemia. Follow me as we dive deeper. Alpha thalassemia has increased prevalence in people of Asian and African descent, and you may see target cells on the peripheral smear. The clinical outcome depends on the number of alpha-globin genes deleted. If only one gene is deleted, the result is alpha thalassemia minima, which causes no anemia, making the person a silent carrier. If two genes are deleted, the person has alpha thalassemia minor, which presents with mild microcytic, hypochromic anemia. When three genes are deleted, the condition becomes hemoglobin H disease, also called HbH, where the excess beta-globin chains form beta-4 tetramers, leading to moderate to severe microcytic hypochromic anemia. If all four alpha-globin genes are deleted, the result is hemoglobin Bart's disease, where there is no alpha-globin at all, and the excess gamma-globin forms gamma-4 tetramers. This leads to hydrops fetalis, a condition that is incompatible with life. Let's talk about beta thalassemia, which results from a point mutation in either the splice sites or the Kozak consensus sequence, which is part of the promoter region on chromosome 11. This leads to a reduction in beta-globin synthesis, known as beta, or a complete absence, which is called beta. The condition has a high prevalence in Mediterranean populations, and its severity depends on the number of mutated beta-globin genes. If only one gene is mutated, the condition is called beta thalassemia minor, and it causes a mild microcytic anemia, often with increased hemoglobin A2. When two beta-globin genes are mutated, the diagnosis is beta thalassemia intermedia, and this can cause variable anemia, which may range from mild or asymptomatic, all the way to severe and transfusion-dependent. In beta thalassemia major, also known as Cooley anemia, it causes a severe microcytic anemia. You will see target cells on the smear and marked anisopoikilocytosis, and patients usually require frequent blood transfusions, which increase the risk of secondary hemochromatosis. Bone marrow expansion can cause a crew-cut appearance on skull X-rays, due to skeletal deformities. Are you following me? Because there's more. Such patients also develop extramedullary hematopoiesis, which leads to hepatosplenomegaly, and they're at increased risk for a plastic crisis triggered by parvovirus B19. Their labs will show increased hemoglobin F and hemoglobin A2, and symptoms typically begin after 6 months of age, once HbF declines, since it has a protective effect early on. Chronic hemolysis can lead to the formation of pigmented gallstones. In another variant, if the person inherits one sickle gene and one beta thalassemia gene, the result is sickle cell beta thalassemia, which causes mild to moderate sickle cell disease, depending on whether beta-globin synthesis is reduced or absent. Let's shift to lead poisoning, where lead inhibits ferrochelatase and ALA dehydratase, both crucial enzymes for heme synthesis, which leads to a reduction in heme and an increase in RBC protoporphyrin. Lead also inhibits rRNA degradation, so red blood cells retain aggregates of rRNA, resulting in basophilic stippling. Clinical signs can be remembered with the LLEAAD acronym, which stands for lead lines on the gingiva, known as Burton lines, and on the metaphyses of long bones, which are visible on X-rays. There is also encephalopathy, erythrocyte basophilic stippling, abdominal colic, sideroblastic anemia, and drops, referring to wrist and foot drop. Listen carefully. Treatment involves chelation therapy using agents like Saximer, EDTA, or dimercaprol. Children are especially at risk due to exposure to chipped paint in old houses built before 1978, while adults typically get exposed through workplace environments, such as battery manufacturing or handling ammunition. Now let's talk about sideroblastic anemia, which can be genetic, like an X-linked defect in ALA synthase, acquired, as seen in myelodysplastic syndromes, or reversible, due to alcohol use, lead poisoning, vitamin B6 deficiency, copper deficiency, or certain drugs, including isoniazid and linezolid. Here, pay attention. Lab findings in sideroblastic anemia show increased iron, normal or decreased TIBC, and increased ferritin. In the bone marrow, you'll see ringed sideroblasts, which are erythroblasts with iron-laden, Prussian blue, stained mitochondria arranged in a ring around the nucleus. On the peripheral blood smear, you'll observe basophilic stippling of RBCs, just like in lead poisoning. Some acquired cases of sideroblastic anemia may even be normocytic or macrocytic, depending on the underlying cause. The main treatment is pyridoxine, also known as vitamin B6, which is a vital cofactor for the ALA synthase enzyme. Macrocytic anemias, where the mean corpuscular volume, or MCV, is greater than 100 femtoliters. One major type is megaloblastic anemia, which occurs due to impaired DNA synthesis. This causes the nuclear maturation of precursor cells in the bone marrow to lag behind the maturation of their cytoplasm. Causes include vitamin B12 deficiency, folate deficiency, and certain medications, like hydroxyurea, phenytoin, methotrexate, and sulfa drugs. The findings include RBC macrocytosis, hypersegmented neutrophils, which are seen clearly under microscopy, and a smooth, inflamed tongue, also known as glossitis. Now listen carefully. Folate deficiency can be caused by malnutrition, especially from chronic alcohol overuse, or due to malabsorption, and it can also result from drugs such as methotrexate, trimethoprim, and phenytoin. It may occur when the body has increased folate requirements, like during hemolytic anemia or pregnancy. Lab findings will show elevated homocysteine, while methylmalonic acid remains normal. And you should remember this: there are no neurologic symptoms in folate deficiency, which helps you distinguish it from vitamin B12 deficiency. Are you following me? Let's move on to vitamin B12, also known as cobalamin, deficiency. It can result from pernicious anemia, malabsorption, as seen in Crohn's disease, or pancreatic insufficiency, and can also occur after gastrectomy or due to insufficient intake, particularly in strict vegans. It may also be caused by infection with Diphyllobothrium latum, the fish tapeworm. Laboratory values will show increased homocysteine and increased methylmalonic acid. Neurologic symptoms are important. These include reversible dementia, and a condition called subacute combined degeneration, involving the spinocerebellar tract, the lateral corticospinal tract, and the dorsal columns, due to B12's role in fatty acid metabolism and myelin synthesis. Now listen carefully. While folate supplementation in someone with vitamin B12 deficiency can correct the anemia, it can actually worsen the neurologic symptoms, so diagnosis must be precise. Historically, this was done with the Schilling test, which helps determine if the problem is due to dietary insufficiency or malabsorption. It's worth noting that anemia due to insufficient vitamin B12 intake may take several years to develop, because the liver stores B12, unlike folate deficiency, which can arise within weeks to months. Are you ready for more? Now let's talk about orotic aciduria, a rare condition caused by an inability to convert orotic acid to UMP in the de novo pyrimidine synthesis pathway, due to a defect in UMP synthase. It is an autosomal recessive disorder, and usually presents in children with failure to thrive, developmental delay, and megaloblastic anemia that is refractory to folate and B12 supplementation. There is no hyperammonemia, which helps distinguish it from ornithine transcarbamylase deficiency, which also has elevated orotic acid but includes hyperammonemia. You'll find orotic acid in the urine, and the treatment involves giving uridine monophosphate or uridine triacetate, which bypasses the mutated enzyme. Now let's talk about non-megaloblastic anemia, which is a type of macrocytic anemia where DNA synthesis remains normal. Common causes include chronic alcohol overuse and liver disease. In these cases, the blood smear shows macrocytic red blood cells, but without hypersegmented neutrophils, which helps differentiate it from megaloblastic causes. Now moving on to something more specific, let's review Diamond-Blackfan anemia, which is a congenital form of pure red cell aplasia. This is different from Fanconi anemia, which causes pancytopenia. Diamond-Blackfan anemia causes a rapid-onset anemia, usually within the first year of life, and it results from an intrinsic defect in erythroid progenitor cells. Pay the fucking attention. Lab findings often show an increased percentage of hemoglobin F, even though the total hemoglobin is decreased. Clinically, you may see short stature, craniofacial abnormalities, and upper extremity malformations, like triphalangeal thumbs, which appear in up to 50% of cases. Just remember this clever clue: a pure diamond causes pure red cell aplasia, to help lock it in your memer. Now let's talk about normocytic, normochromic anemias, which are classified into two major categories, non-hemolytic and hemolytic. When dealing with hemolytic anemias, we divide them further, based on the cause of hemolysis, whether it is intrinsic or extrinsic to the red blood cell, and by the location of the hemolysis, either intravascular or extravascular. Hemolysis can lead to increased levels of lactate dehydrogenase, or LDH, as well as elevated reticulocytes, unconjugated bilirubin, and urobilinogen in the urine, and may even cause pigmented gallstones to form, all due to excessive red cell breakdown. Are you following me? The findings in intravascular hemolysis include decreased haptoglobin, and the presence of schistocytes on blood smear. You may also detect hemoglobinuria, hemosideruria, and urobilinogen in the urine. Notable causes include mechanical hemolysis, such as from a prosthetic valve, as well as paroxysmal nocturnal hemoglobinuria, and microangiopathic hemolytic anemias. In contrast, extravascular hemolysis occurs when splenic macrophages clear red blood cells from circulation. This leads to splenomegaly, and on the peripheral smear, you'll often see spherocytes, most commonly due to hereditary spherocytosis or autoimmune hemolytic anemia. Let's talk about what you won't see in extravascular hemolysis. Unlike intravascular forms, here there is no hemoglobinuria or hemosideruria, but urobilinogen may still be present in the urine. So now, turning our focus to the non-hemolytic, normocytic anemias, we begin with anemia of chronic disease. This form arises due to inflammation, for example, increased interleukin-6, which leads to increased hepcidin. Hepcidin, produced by the liver, binds ferroportin on intestinal mucosal cells and macrophages, blocking iron transport. This leads to decreased release of iron from macrophages, and reduced iron absorption from the gut. You should remember this well. It's often associated with chronic infections, neoplastic disorders, chronic kidney disease, and autoimmune diseases, including systemic lupus erythematosus and rheumatoid arthritis. Lab findings show reduced iron, reduced total iron binding capacity, and increased ferritin levels. It typically presents as normocytic anemia, though it may shift toward being microcytic over time. Treatment should target the underlying cause of inflammation, and may involve judicious use of blood transfusion, or the use of erythropoiesis-stimulating agents, like EPO, especially in chronic kidney disease. Now listen carefully as we move on to aplastic anemia, which results from failure or destruction of hematopoietic stem cells. There are several causes, all of which reduce cellular content from inside the bone marrow cavity. These include radiation exposure, certain viral infections, such as EBV, HIV, and hepatitis viruses, and Fanconi anemia, which is an autosomal recessive DNA repair defect that leads to bone marrow failure. On a complete blood count, you may see normocytosis or macrocytosis. Other signs include short stature, café au lait spots, thumb or radial abnormalities, and a predisposition to malignancy. Are you ready for the next part? Additional causes of aplastic anemia include idiopathic forms, often immune-mediated or due to primary stem cell defects, and it may also follow an episode of acute hepatitis. Medications such as benzene, chloramphenicol, alkylating agents, and antimetabolites are also known culprits. Lab findings show a reduced respiratory count, and increased erythropoietin levels. Clinically, you'll see pancytopenia, meaning anemia, leukopenia, and thrombocytopenia, which is different from an aplastic crisis, where only anemia occurs. The red cells usually have normal morphology, but the bone marrow appears hypocellular, filled with fatty infiltration, including increased adipose tissue. Listen carefully. Symptoms of aplastic anemia include fatigue, malaise, pallor, purpura, mucosal bleeding, petechiae, and frequent infections. Treatment involves withdrawing the offending agent, using immunosuppressive regimens, such as antithymocyte globulin and cyclosporin, or even performing a bone marrow allograft. Supportive care may include RBC and platelet transfusions, and for some patients, bone marrow stimulation with agents like GM-CSF may also be beneficial. Listen carefully. Intrinsic hemolytic anemias are described through various causes and features, so let's begin with hereditary spherocytosis. It is primarily autosomal dominant, and due to a defect in proteins interacting with the red blood cell membrane skeleton and plasma membrane, such as ankyrin, band 3, protein 4.2, and spectrin. The red blood cells become small and round with no central pallor, the surface area is reduced, dehydration increases, and this leads to an elevated mean corpuscular hemoglobin concentration, which causes premature removal by the spleen, that means extravascular hemolysis. Clinical findings include splenomegaly, pigmented gallstones, and aplastic crisis triggered by parvovirus B19 infection. Lab findings show reduced mean fluorescence of red cells in the eosin-5 maleimide binding test, increased fragility in the osmotic fragility test, meaning the cells hemolyze in hypotonic solutions. Mean corpuscular volume is normal or reduced, with an abundance of red blood cells, and the treatment is splenectomy. Are you following me? Now let's talk about paroxysmal nocturnal hemoglobinuria, a condition caused by a mutation in hematopoietic stem cells, leading to increased complement-mediated intravascular hemolysis, especially at night. It is acquired through a PIGA mutation, which impairs GPI anchor synthesis for protective proteins like decay accelerating factor, CD55, and membrane inhibitor of reactive lysis, CD59. These normally shield the red cell membrane from complement attack. The clinical triad includes Coombs-negative hemolytic anemia, usually intravascular, pancytopenia, and venous thrombosis, such as Budd-Chiari syndrome. Patients may notice pink or red urine in the morning, and it is associated with aplastic anemia and acute leukemias. Lab findings show CD55 and CD59 negative red blood cells on flow cytometry, and the treatment is eculizumab, which targets terminal complement protein C5. Let's continue with G6PD deficiency, which is X-linked recessive. The defect in glucose 6-phosphate dehydrogenase leads to reduced NADPH, and therefore reduced glutathione, making red blood cells more susceptible to oxidative stress. Triggers include sulfa drugs, antimalarials, and fava beans, and the result is hemolysis, both extravascular and intravascular. Symptoms include back pain and hemoglobinuria a few days after oxidative stress. Laboratory tests reveal decreased G6PD activity, which might appear normal during acute hemolysis, and blood smear shows red blood cells with Heinz bodies and bite cells. You should remember this: stress makes me eat bites of fava beans with Heinz ketchup. Are you ready for the next one? Pyruvate kinase deficiency is autosomal recessive, and due to a defect in pyruvate kinase, ATP production is reduced, which makes red blood cells rigid and leads to extravascular hemolysis. There is an increase in 2,3-BPG, which in turn reduces hemoglobin's affinity for oxygen. This condition presents as hemolytic anemia in a newborn, and the blood smear shows Burr cells, which are also called echinocytes. Now listen carefully: sickle cell anemia results from a point mutation in the beta-globin gene. This mutation leads to a single amino acid substitution. Glutamic acid is replaced by valine, which alters the hydrophobic region of the beta-globin chain. This change causes hemoglobin molecules to aggregate, leading to both extravascular and intravascular hemolysis. Factors like decreased oxygen, high altitude, or acidosis can precipitate sickling because deoxygenated HbS polymerizes, leading to vaso-occlusive disease. Newborns are initially asymptomatic due to increased fetal hemoglobin and decreased sickle hemoglobin. Heterozygotes, meaning those with sickle cell trait, have resistance to malaria. Sickle cells are crescent-shaped, and a skull X-ray shows a crew-cut appearance due to marrow expansion from increased erythropoiesis, a finding also seen in thalassemias. You should remember this part. Complications include aplastic crisis, which is a transient arrest of erythropoiesis caused by parvovirus B19, and autosplenectomy, marked by Howell-Jolly bodies, leading to increased risk of infection from encapsulated organisms like Salmonella osteomyelitis. There can also be splenic infarct or sequestration crisis, painful vaso-occlusive crises such as dactylitis, which is painful swelling of hands and feet, priapism, acute chest syndrome with respiratory distress and new pulmonary infiltrates on chest X-ray, which is a common cause of death, avascular necrosis, and stroke. Sickling in the renal medulla due to low oxygen tension leads to renal papillary necrosis and hematuria, which can also occur in sickle cell trait. Hemoglobin electrophoresis reveals absent or reduced HbA, increased HbF, and markedly increased HbS. The treatment includes hydroxyurea, which increases HbF, and adequate hydration. Let's wrap up with HBC disease, which results from a glutamic acid to lysine mutation in the beta-globin gene, and causes extravascular hemolysis. Individuals with HBSC, meaning one of each mutant gene, tend to have a milder condition than those with HBSS. In homozygotes, the blood smear reveals hemoglobin crystals inside red blood cells, along with target cells. Let's talk about extrinsic hemolytic anemias, and we'll begin with autoimmune hemolytic anemia. This is a normocytic anemia that is usually idiopathic, and importantly, it is Coombs positive. There are two types you should remember. First, warm AIHA. This is a chronic anemia in which primarily IgG causes extravascular greater than intravascular hemolysis. It's commonly seen in conditions like SLE, CLL, and it can also be triggered by certain drugs such as beta-lactams and alpha-methyldopa. You should remember the phrase, "warm weather is good," to link warmth with IgG. Listen carefully, the second type is cold AIHA. This is an acute anemia in which primarily IgM and complement cause RBC agglutination, and again, extravascular hemolysis is greater than intravascular hemolysis, but this happens upon exposure to cold. Patients might present with painful, blue fingers and toes. It's typically seen in CLL, Mycoplasma pneumoniae infections, and infectious mononucleosis. On peripheral blood smear, you'll notice spherocytes and agglutinated RBCs. As for treatment, warm AIHA is managed with steroids, rituximab, and splenectomy if refractory, while cold AIHA is treated with cold avoidance and rituximab. Are you following me? Because now we're moving on to drug-induced hemolytic anemia. This condition is most commonly due to antibody-mediated immune destruction of RBCs or from oxidant injury via free radical damage, which may be worse in patients with G6PD deficiency. Common causes include antibiotics like penicillins and cephalosporins, NSAIDs, immunotherapy, and chemotherapy. If you see spherocytes, think of immune hemolysis, and if you see BITE cells, think of oxidative hemolysis. Both extravascular and intravascular hemolysis can occur. Have you heard about microangiopathic hemolytic anemia? In this condition, RBCs are damaged as they pass through obstructed or narrowed blood vessels, leading to intravascular hemolysis. It's seen in disorders such as DIC, TTP or HUS, SLE, HALLP syndrome, and hypertensive emergency. On a peripheral blood smear, you will see schistocytes, also known as helmet cells, due to mechanical destruction. Remember, schisto means to split, and that describes the red cells perfectly here. Now we turn to macroangiopathic hemolytic anemia. In this type, prosthetic heart valves and aortic stenosis may also cause hemolytic anemia, and again, it's due to mechanical destruction of red blood cells. Like before, schistocytes will appear on the peripheral blood smear. You should remember this next one, hemolytic anemia due to infection. This involves increased destruction of red blood cells, and it's typically caused by infections like malaria and babesia. What about shift gears and talk about leukopenias? Under cell type and cell count, we begin with neutropenia, which is defined as an absolute neutrophil count less than 1,500 cells per cubic millimeter. Severe infections are typical when the count drops below 500 cells per cubic millimeter. Causes include sepsis or post-infection, various drugs including chemotherapy, aplastic anemia, autoimmunity such as SLE, radiation, and congenital conditions. Next up is lymphopenia, defined as an absolute lymphocyte count below 1,500 cells per cubic millimeter, or below 3,000 in children. The causes here include HIV, DeGeorge syndrome, SCID, SLE, glucocorticoids, radiation, sepsis, and postoperative states. Now listen carefully, because the last type is eosinopenia, where the absolute eosinophil count is less than 30 cells per cubic millimeter. This can be caused by Cushing's syndrome and the use of glucocorticoids. Interestingly, glucocorticoids cause neutrophilia, even though they lead to eosinopenia and lymphopenia. They do this by reducing activation of neutrophil adhesion molecules, which impairs their migration out of the vasculature into inflamed tissues. In contrast, glucocorticoids sequester eosinophils in lymph nodes and induce apoptosis of lymphocytes. Let's talk about heme synthesis, porphyrias, and lead poisoning. The porphyrias are either hereditary or acquired conditions that involve defective heme synthesis, and this defect leads to the accumulation of heme precursors. Similarly, lead poisoning disrupts heme synthesis by inhibiting specific enzymes, and this creates a condition with overlapping clinical features. Shockingly, in lead poisoning, the enzymes that are affected include ferrochelatase and ALA dehydratase. As a result, there's an accumulation of protoporphyrin and ALA in the blood. Patients typically present with microcytic anemia, and on a peripheral smear, you might see basophilic stippling, while in the bone marrow, you'll find ringed sideroblasts. This condition also comes with gastrointestinal and kidney disease. Are you following me? Because now we'll explore acute intermittent porphyria, which is caused by a mutation in the enzyme porphobilinogen deaminase. This is an autosomal dominant mutation. The substrates that accumulate in this case are porphobilinogen and ALA. The symptoms can be remembered as the 5 Ps, and here they are. First, a painful abdomen. Second, port wine, colored pee. Third, polyneuropathy. Fourth, psychological disturbances. And fifth, symptoms are often precipitated by factors that increase ALA synthase, such as drugs like CYP450 inducers, alcohol, or starvation. The treatment involves giving hemin and glucose. Turning to porphyria cutanea tarda, which involves a deficiency of the enzyme uroporphyrinogen decarboxylase. This leads to the buildup of uroporphyrin, which causes tea-colored urine. The main clinical features include blistering cutaneous photosensitivity and hyperpigmentation. It's important to note that this is the most common porphyria, and it can be worsened by alcohol consumption. The causes may be familial, or linked to hepatitis C infection. For treatment, the recommended approaches are phlebotomy, sun avoidance, and the use of antimalarials such as hydroxychloroquine. Talking about iron poisoning, which occurs due to free radical formation and membrane lipid peroxidation, leading to cell death. This condition can present in either acute or chronic forms. In the acute setting, there's a significantly increased mortality rate especially associated with accidental ingestion by children, since adult iron tablets may look like candy. Are you following me? In chronic cases, it's commonly seen in patients with primary, that is hereditary hemochromatosis, or secondary hemochromatosis, such as those receiving chronic blood transfusions for thalassemia or sickle cell disease. The symptoms and signs of acute iron poisoning include abdominal pain, vomiting, and GI bleeding, and you might observe a radiopaque pill on X-ray. This condition may progress to anion gap metabolic acidosis and even multi-organ failure, and over time, it may lead to scarring with gastrointestinal obstruction. Now listen carefully. In chronic iron overload, patients may develop arthropathy, cirrhosis, cardiomyopathy, diabetes mellitus, and skin pigmentation, often referred to as bronze diabetes, along with hypogonadism. The treatment for acute iron toxicity involves chelation therapy, using agents like deferoxamine or deferocyrox, and may include gastric lavage. For chronic cases, the preferred treatment is regular therapeutic phlebotomy, unless it is contraindicated, for example, in anemia, and may be also chelation. Our next topic is coagulation disorders, starting with the tests used to evaluate different parts of the coagulation cascade. The PT, which stands for prothrombin time, tests the function of the common and extrinsic pathways, and specifically evaluates factors 1, 2, 5, 7, and 10. A defect in this pathway leads to an increased PT, and you can remember this by the phrase, play tennis outside, since the extrinsic pathway is being tested. Now listen carefully. The INR, or International Normalized Ratio, is calculated by dividing the patient's PT by the control PT, where a value of 1 is considered normal, and anything greater than 1 indicates a prolonged PT. This is the most common test used to monitor patients on warfarin, because warfarin works by prolonging the INR. Let's move on to the PTT, or partial thromboplastin time, which tests the common and intrinsic pathways. This test evaluates all factors except 7 and 13, and when there's a defect, the PTT is increased. To help you remember, think, play table tennis inside, since this refers to the intrinsic pathway. Now let's not forget about the TT, or thrombin time, which measures how fast fibrinogen is converted to fibrin. This time is prolonged by anticoagulants, and also by conditions like hypofibrinogenemia, disseminated intravascular coagulation, or liver disease. Are you following me? Coagulation disorders can result either from clotting factor deficiencies or from acquired factor inhibitors, and the most common inhibitors act against factor VIII. We diagnose these using a mixing study, where normal plasma is added to the patient's plasma. If the problem is a clotting factor deficiency, the test will correct, meaning the PT or PTT will return to normal range. But if there is a factor inhibitor, the abnormal values will not correct. Now listen carefully. Let's discuss specific disorders. In hemophilia A, B, or C, the PT stays normal, while the PTT is increased, because these are intrinsic pathway defects. In hemophilia A, there is a deficiency of factor VIII, and it's inherited in an X-linked recessive pattern. To help remember, say, hemophilia 8. In hemophilia B, there's a deficiency of factor IX, also X-linked recessive. While hemophilia C involves a deficiency of factor XI, and this one is autosomal recessive. You should remember this: hemorrhage in hemophilia can cause bleeding into joints, especially the knee, known as hemarthrosis, along with easy bruising, and excessive bleeding after trauma or surgical procedures, like dental extractions. Treatment varies depending on the type. For hemophilia A, we use desmopressin, factor VIII concentrate, or emicizumab. For hemophilia B, we give factor IX concentrate, and for hemophilia C, the treatment is factor XI concentrate. Now let's finish with vitamin K deficiency, where both the PT and PTT are increased, showing a general coagulation defect, but bleeding time remains normal. That's because vitamin K is necessary for the activity of factors 2, 7, 9, and 10, as well as protein C and protein S. Now let's talk about platelet disorders, and you should remember, all of these disorders are marked by increased bleeding time, along with mucous membrane bleeding and microhemorrhages, like petechiae and epistaxis. While the platelet count is usually low, it may still be normal in disorders that affect platelet function, rather than their number. Let's begin with Bernard-Soulier syndrome. Platelet number may be normal or decreased. It is an autosomal recessive disorder involving a defect in platelet adhesion. There's a reduced expression of GP1B, which leads to decreased platelet binding to von Willebrand factor, or VWF. In lab tests, we see decreased platelet aggregation, and the platelets themselves appear larger than normal. They're often referred to as big platelets. Next comes Glanzmann thrombasthenia, another autosomal recessive disorder. In here still platelet count is normal and bleeding time is increased, but this time the problem lies in platelet aggregation, not adhesion. The defect involves GP2B/3A, also called integrin alpha-2B beta-3, which leads to reduced platelet-to-platelet binding and impaired platelet plug formation. A blood smear will show no platelet clumping, which is a key diagnostic feature. Now listen carefully, we move on to immune thrombocytopenia. Platelet count low and bleeding time is increased where platelets are destroyed in the spleen, most often due to antibodies against GP2B/3A. These antibodies mark the platelets for destruction, and splenic macrophages phagocytose them. This condition may be idiopathic, or it can occur secondary to autoimmune diseases like SLE, viral infections like HIV or HCV, malignancies like chronic lymphocytic leukemia, or certain drugs. On lab studies, you'll find increased megakaryocytes in the bone marrow, and a decreased platelet count. Treatment options include glucocorticoids, IVIG, rituximab, TPO receptor agonists like eltrombopag and romiplastim, and in refractory cases, splenectomy. Are you following me? Let's look at uremic platelet dysfunction, which is seen in patients with renal failure. In these patients, uremic toxins accumulate, interfering with both platelet adhesion and aggregation, resulting in a functional defect, even if the platelet count remains normal. Now listen carefully, we turn to the thrombotic microangiopathies, which can resemble DIC, but importantly, they do not show lab signs of consumptive coagulopathy. In other words, PT and PTT are usually normal, and fibrinogen is not decreased, because the coagulation cascade is not activated. We begin with thrombotic thrombocytopenic purpura, or TTP, which typically affects adult females. It is caused by an inhibition or deficiency of a DAMPS13, a VWF metalloprotease, which leads to impaired degradation of VWF multimers. This results in increased large VWF multimers, causing enhanced platelet adhesion and aggregation, and the formation of microthrombi. Now let's contrast that with hemolytic uremic syndrome, or HUS, which typically affects children, and is most often caused by Shiga toxin, producing Escherichia coli, particularly the O157H7 serotype. This toxin leads to severe endothelial dysfunction, triggering the clinical features. Both conditions present with a triad, thrombocytopenia, shown by low platelet count, microangiopathic hemolytic anemia, shown by low hemoglobin, schistocytes, and elevated LDH, and acute kidney injury, with elevated creatinine. But here's how you tell them apart. TTP also includes fever and neurologic symptoms, while HUS is marked by bloody diarrhea. You should remember this. Normal PT and PTT help distinguish TTP and HUS from DIC, where those values are typically elevated, due to consumptive coagulopathy. Treatment for TTP includes plasma exchange, glucocorticoids, and rituximab, while supportive care is the mainstay for HUS. Now listen carefully, we're moving on to mixed platelet and coagulation disorders, which involve defects in both platelet function and the clotting cascade. One of the most important and common conditions in this category is von Willebrand disease, which affects the intrinsic pathway of coagulation. Here, there is a reduced quantity or function of von Willebrand factor, which not only impairs platelet to VWF adhesion, but also leads to a prolonged PTT, since VWF protects factor VIII. This disorder is usually autosomal dominant, and while the bleeding is often mild, it is actually the most common inherited bleeding disorder. Patients may present with menorrhagia, or frequent nosebleeds. Bleeding time is increased, but platelet count, PT, and PTT can be normal or slightly prolonged. Treatment involves VWF concentrates, or desmopressin, which helps by releasing endothelial stores of VWF. A more severe condition, disseminated intravascular coagulation, or DIC, which involves widespread activation of clotting factors, leading to both thromboembolism and bleeding. Because clotting factors are consumed rapidly, patients develop increased PT, increased PTT, and increased bleeding time, along with low platelet counts. This condition may occur acutely, where it can be life-threatening, or it may be chronic, especially if the body can compensate by producing new clotting factors. Causes include heat stroke, snake bites, gram-negative sepsis, trauma, obstetric complications, acute pancreatitis, malignancy, nephrotic syndrome, and blood transfusions. Just remember the mnemonic: stop making new thrombi. Lab findings include schistocytes, elevated D-dimer, low fibrinogen, and reduced factors V and VIII. Are you following me? Let's now shift our focus to hereditary thrombophilias, which are a group of autosomal dominant disorders that lead to a hypercoagulable state, meaning an increased tendency to form blood clots. Let's start with antithrombin deficiency, which doesn't directly affect PT, PTT, or thrombin time, but it does blunt the rise in PTT after administering standard heparin. This condition can also be acquired, especially in renal failure or nephrotic syndrome, where antithrombin is lost in the urine, leading to reduced inhibition of factors 2A and 10A. Next, we have the well-known factor V Leiden, which results from a guanine to adenine point mutation, creating an arginine to glutamine substitution near the cleavage site, making factor V resistant to activated protein C. This mutation increases the risk for deep vein thrombosis, cerebral venous thrombosis, and recurrent pregnancy loss. Now let's talk about protein C or S deficiency, which leads to reduced inactivation of factors 5A and 8A, thereby enhancing coagulation. An important clinical association is the risk of warfarin-induced skin necrosis. Just remember, protein C cancels, and protein S stops coagulation. And finally, the prothrombin G20210A mutation is caused by a point mutation in the 3' untranslated region, resulting in increased production of prothrombin, which then leads to higher plasma levels and an increased risk of venous thrombosis. Now listen carefully, let's talk about blood transfusion therapy, which involves different components, each with specific dosage effects and clinical uses. Starting with packed red blood cells, these increase hemoglobin and oxygen carrying capacity. For every unit transfused, hemoglobin rises by approximately 1 gram per deciliter, and hematocrit increases by about 3%. This is used in cases of acute blood loss or severe anemia. Moving on to platelets, each unit raises the count by around 30,000 per microliter, or approximately 5,000 per cubic millimeter, and they are administered to stop significant bleeding, especially in thrombocytopenia, or when there are qualitative platelet defects. Now let's talk about fresh frozen plasma, or prothrombin complex concentrate. These raise coagulation factor levels. FFP contains all coagulation factors and plasma proteins, while PCC mainly includes factors 2, 7, 9, and 10, along with proteins C and S. These are particularly useful in cirrhosis, or when there's a need for rapid anticoagulation reversal. Next is cryoprecipitate, which provides fibrinogen, factor 8, factor 13, von Willebrand factor, and fibronectin, and is used in coagulation factor deficiencies, especially those involving fibrinogen or factor 8. You should remember this: albumin works by increasing intravascular volume and oncotic pressure, and it's typically used after paracentesis, or during therapeutic plasmapheresis. Now, although blood transfusion saves lives, it carries certain risks. These include infections, although the risk is low, as well as transfusion reactions, and circulatory overload, also called TACO, which may cause pulmonary edema and hypertension. There's also the risk of TRALI, or transfusion-related acute lung injury, which results in non-cardiogenic pulmonary edema, hypoxia, and inflammation, along with hypotension. Now listen carefully: iron overload is another concern, especially with repeated transfusions, and may lead to secondary hemochromatosis. In addition, hypocalcemia may occur, since citrate, used in storage, is a calcium chelator, and hyperkalemia can develop due to RBC lysis, particularly in older blood units. Are you ready for the next topic? Let's compare leukemia and lymphoma. Leukemia is a lymphoid or myeloid neoplasm, characterized by widespread bone marrow involvement, and tumor cells are usually seen in the peripheral blood. On the other hand, lymphoma presents as a discrete tumor mass, usually arising from lymph nodes, though it may also involve atypical sites and sometimes mimics leukemia in its presentation. Now let's dive into Hodgkin versus non-Hodgkin lymphoma. Both types may present with constitutional symptoms, also known as B symptoms, including low-grade fever, night sweats, and weight loss. Hodgkin lymphoma typically involves a single group of lymph nodes with contiguous spread, and the stage is the strongest prognostic factor, which is why it tends to have a better prognosis. In contrast, non-Hodgkin lymphoma often involves multiple lymph node groups, with extranodal involvement, non-contiguous spread, and typically a worse prognosis. Hodgkin characterized by Reed-Sternberg cells, while non-Hodgkin lymphoma a majority involve B cells, rarely of T cell lineage most cases. Hodgkin occur in young adults, or in those over 55, showing a bimodal distribution. It is also associated with Epstein-Barr virus. Non-Hodgkin, on the other hand, can occur in children or adults and may be linked to autoimmune diseases, or infections like HIV, EBV, and HTLV. Now let's quickly walk through the subtypes of Hodgkin lymphoma. All Hodgkin lymphoma known by presence of Reed-Sternberg cells, which are large, bilobed tumor cells that look like owl eyes under the microscope. These are of B-cell origin, and they are CD15 positive and CD30 positive. The nodular sclerosis subtype is the most common. The mixed cellularity type is associated with eosinophilia, and is often seen in immunocompromised patients. The lymphocyte-rich subtype has the best prognosis. Just remember, the rich have better bank accounts. Meanwhile, the lymphocyte-depleted subtype has the worst prognosis, and is more common in immunocompromised patients, because the poor have worse bank accounts. Now listen carefully: we're diving into non-Hodgkin lymphoma, and we'll begin with the neoplasms of mature B cells. First is Burkitt lymphoma, which typically affects adolescents or young adults, and is sometimes nicknamed Burkitt lymphoma, because it's more common in kids. It involves a T8/14 translocation, which swaps the c-MYC gene on chromosome 8 with the heavy-chain immunoglobulin on chromosome 14. Microscopically, it shows a starry sky appearance, with sheets of lymphocytes and scattered, tingible body macrophages. This disease is associated with EBV, and in endemic African cases, it commonly presents as a jaw lesion, while in sporadic cases, it often involves the pelvis or abdomen. Are you following me? Next up is diffuse large B-cell lymphoma, which is usually seen in older adults, though about 20% of cases occur in children. This lymphoma is linked to mutations in BCL2 and BCL6, and it is in fact the most common type of non-Hodgkin lymphoma in adults. Moving on to follicular lymphoma, which typically affects adults and features a T14/18 translocation, fusing the heavy chain immunoglobulin on chromosome 14 with BCL2 on chromosome 18. This type has an indolent course, presenting with painless lymphadenopathy that waxes and wanes over time. And remember, BCL2 normally acts to inhibit apoptosis. Now let's talk about mantle cell lymphoma, which affects adult males much more often than females. It's associated with a T11/14 translocation, involving cyclin D1 on chromosome 11 and the heavy chain immunoglobulin on chromosome 14, and the cells are CD5 positive. This lymphoma is very aggressive, and patients usually present in late-stage disease. Following that is marginal zone lymphoma, another adult-onset condition, often associated with a T11/18 translocation. This lymphoma is linked to chronic inflammation, such as Sjogren's syndrome or chronic gastritis, and the malt lymphoma subtype may even regress with H. pylori eradication. Are you ready for more? Let's explore primary central nervous system lymphoma, which typically occurs in adults, and is EBV-related, often seen in patients with HIV or AIDS. It is actually considered an AIDS-defining illness, and it presents variably with confusion, memory loss, and sometimes seizures. It forms a CNS mass, usually a single, ring-enhancing lesion on MRI, and occurs in immunocompromised patients. However, it's essential to distinguish it from toxoplasmosis, using CSF analysis or other laboratory tests. Now listen carefully, we're shifting gears to the neoplasms of mature T cells. One of the major ones is adult T-cell lymphoma, seen in adults, and caused by HTLV, which is associated with intravenous drug use. It usually presents with cutaneous lesions, and is common in Japan, West Africa, and the Caribbean. You can think of it as T-cell in Tokyo. It may also cause lytic bone lesions, and leads to hypercalcemia. Lastly, we have cutaneous T-cell lymphoma, which is a heterogeneous group of T-cell neoplasms that affect the skin, and sometimes involve the blood, lymph nodes, or viscera. The most common subtype is called mycosis fungoides, which begins as erythematous patches in sun-protected areas, and then progresses to plaques, and eventually to tumors. Now listen carefully, plasma cell dyscrasias are a group of disorders marked by the proliferation of a single plasma cell clone, and they typically cause overproduction of a monoclonal immunoglobulin, also called a paraprotein. These conditions are mostly seen in older adults, and are initially screened using serum protein electrophoresis, where the M spike shows up, representing the overproduction of monoclonal Ig. For further evaluation, we use serum immunofixation, and the serum free light chain assay. When urinary involvement is suspected, we need urine protein electrophoresis and urine immunofixation, because a urine dipstick only detects albumin, and won't identify the other proteins. Diagnostic confirmation always requires a bone marrow biopsy, and if you look at the peripheral blood smear, you might see rouleaux formation, where RBCs are stacked like poker chips. Now let's talk about multiple myeloma, which involves overproduction of IgG, the most common type, followed by IgA, and sometimes Ig light chains. The clinical features can be remembered with the CRAB mnemonic, which stands for hypercalcemia, caused by cytokines like IL-1, TNF-alpha, and RANKL that increase osteoclast activity, renal insufficiency, anemia, and bone lytic lesions, which appear as punched-out areas on X-ray, often causing back pain or pathologic fractures. You should remember that complications include increased infection risk, and primary amyloidosis of the AL type. On urinalysis, you may find Ig light chains, also known as Bence-Jones proteinuria, but the urine dipstick will be negative. A bone marrow biopsy will show more than 10% monoclonal plasma cells, with clock face chromatin, and intracytoplasmic inclusions containing immunoglobulin. Are you following me? Now let's discuss Waldenström macroglobulinemia, where there is overproduction of IgM, which is called macroglobulinemia because IgM is the largest immunoglobulin. The clinical features include anemia, constitutional B symptoms, lymphadenopathy, hepatosplenomegaly, and especially hyperviscosity, which may manifest as headache, bleeding, blurry vision, or ataxia, along with peripheral neuropathy. When you do a funduscopy, the retinal veins may appear dilated, segmented, and tortuous, described as a sausage-link appearance. A bone marrow biopsy will show more than 10% monoclonal B lymphocytes, with plasma cell features, called lymphoplasmacytic lymphoma, and you may also see intranuclear pseudoinclusions containing IgM. Now let's turn to monoclonal gammopathy of undetermined significance, which features overproduction of any immunoglobulin type, with an M spike of less than 3 grams per deciliter. These patients are asymptomatic, and importantly, they show no Crab findings. However, there is a 1 to 2% annual risk of progressing to multiple myeloma. On bone marrow biopsy, you'll find less than 10% monoclonal plasma cells. Now listen carefully, because we're shifting to myelodysplastic syndromes. These are stem cell disorders that involve ineffective hematopoiesis, which causes defects in cell maturation of non-lymphoid lineages. In these cases, the bone marrow blasts are less than 20%, which helps distinguish them from acute myeloid leukemia, where the blasts are greater than 20%. These syndromes may be caused by de novo mutations, or due to environmental exposure such as radiation, benzene, or chemotherapy. They carry a risk of transformation to AML, and are more common in older adults. One key finding is the pseudopelger-Hute anomaly, where neutrophils have bilobed or duet nuclei, and this anomaly is associated with myelodysplastic syndromes, or may result from drugs, including certain immunosuppressants. Now listen carefully, leukemias are defined by the unregulated growth and differentiation of white blood cells in the bone marrow, which leads to marrow failure. This results in anemia due to decreased red blood cells, infections from reduced mature white blood cells, and hemorrhage because of low platelet counts. Most cases present with elevated circulating white blood cells, meaning malignant leukocytes appear in the blood, although in some instances, the WBC count may be normal or even decreased. Additionally, these malignant cells can infiltrate the liver, spleen, lymph nodes, and skin, a condition called leukemia cutis. Now let's talk about lymphoid neoplasms, starting with acute lymphoblastic leukemia or lymphoma, which occurs most frequently in children, but it's less common in adults, and the prognosis is worse in adults. The T-cell form may present as a mediastinal mass, mimicking superior vena cava syndrome, and this leukemia is associated with Down syndrome. On peripheral blood smear and bone marrow, you'll find a large number of lymphoblasts, and these are TDT positive, which marks pre-T and pre-B cells, and CD10 positive, which marks pre-B cells. This leukemia is highly responsive to therapy, and may spread to the CNS and testes. If the translocation is T12, 21, the prognosis is better, but if it's T9, 22, also known as the Philadelphia chromosome, then the prognosis is worse. Now listen carefully, because next is chronic lymphocytic leukemia, also called small lymphocytic lymphoma, which typically affects people over 60 years old, and is the most common adult leukemia. This is a CD20 positive, CD23 positive, CD5 positive B-cell neoplasm, and it's often asymptomatic, progressing very slowly. On the peripheral blood smear, you'll see smudge cells, also called crushed little lymphocytes, and patients may develop autoimmune hemolytic anemia. Be aware of Richter transformation, where CLL or SLL transforms into an aggressive lymphoma, most commonly diffuse large B-cell lymphoma. Are you following me? Because next is hairy cell leukemia, which typically affects adult males, and it's a tumor of mature B cells. The malignant cells have filamentous, hair-like projections, giving them a fuzzy appearance on light microscopy, and peripheral lymphadenopathy is uncommon. This leukemia causes marrow fibrosis, leading to a dry tap on aspiration, and patients usually present with massive splenomegaly and pancytopenia. It stains positive for tartrate-resistant acid phosphatase, or TRAP, remembered as being trapped in a hairy situation, though flow cytometry has largely replaced the TRAP stain. It's associated with BRAF mutations, and treated with purine analogues, including cladribine and pentostatin. Now let's talk about myeloid neoplasms, beginning with acute myelogenous leukemia, or AML, which has a median onset at 65 years. You'll often find Auer rods, and myeloperoxidase positive cytoplasmic inclusions, especially in acute promyelocytic leukemia, formerly called M3 AML. On peripheral smear, you'll see a high number of circulating myeloblasts, and patients may present with leukostasis, where malignant, rigid cells clog the capillaries, leading to organ damage. Risk factors include prior exposure to alkylating chemotherapy, radiation, benzene, myeloproliferative disorders, and Down syndrome, which is typically associated with acute megakaryoblast leukemia, formerly known as M7 AML. The APL subtype, defined by the T15/17 translocation, responds well to all trans-retinoic acid, or vitamin A, and arsenic trioxide, both of which induce promyelocyte differentiation, though disseminated intravascular coagulation is a common presentation. Now listen carefully, the final type is chronic myelogenous leukemia, or CML, which usually occurs between 45 and 85 years old, with a median age of 64. This leukemia is defined by the Philadelphia chromosome, AT9/22, translocation, producing the BCR-ABL fusion gene, and it involves myeloid stem cell proliferation. Patients show dysregulated production of both mature and maturing granulocytes, including neutrophils, metamyelocytes, myelocytes, and often basophils, along with splenomegaly. CML can accelerate and eventually transform into either AML or ALL, a process known as blast crisis. Fortunately, it responds well to BCR-ABL tyrosine kinase inhibitors, like imatinib. Now listen carefully, myeloproliferative neoplasms are malignant hematopoietic conditions that affect white blood cells and various myeloid cell lines, with differing degrees of severity. The first one is polycythemia vera, a primary polycythemia, which is a disorder marked by increased red blood cells, usually caused by an acquired JAK2 mutation. It may present with intense itching after a shower, known as aquagenic pruritus, and a rare but classic sign is erythromelalgia, which is severe, burning pain with red-blue discoloration, caused by episodic blood clots in the extremities. This condition is also associated with hyperviscosity and thrombosis, which may appear as pulmonary embolism, deep vein thrombosis, or Budd-Chiari syndrome. A key feature is decreased erythropoietin, unlike secondary polycythemia, where EPO is elevated. Treatment involves phlebotomy, hydroxyurea, and ruxolitinib, which is a JAK1/2 inhibitor. Are you following me? Next is essential thrombocythemia, which is defined by a massive proliferation of megakaryocytes and platelets, and patients may experience both bleeding and thrombosis. A blood smear will show a markedly increased number of platelets, some of which may be large or abnormally formed. And just like polycythemia vera, erythromelalgia may also occur in this condition. Now let's talk about myelofibrosis, a disorder marked by atypical megakaryocyte hyperplasia, which leads to increased TGF-beta secretion, stimulating fibroblast activity, and ultimately causing the obliteration of bone marrow by fibrosis. This disease is associated with massive splenomegaly, and on peripheral smear, you'll notice teardrop-shaped red blood cells. They say the bone marrow cries because it's fibrosed, and that's why aspiration results in a dry tap. Now listen carefully as we compare these neoplasms in a concise summary. In polycythemia vera, red cells, white cells, and platelets are all increased, the Philadelphia chromosome is absent, and JAK2 mutations are present. In essential thrombocythemia, red and white cells remain normal, platelets are increased, the Philadelphia chromosome is absent, and JAK2 mutations are found in 30 to 50% of cases. In myelofibrosis, red cells are decreased, white and platelet counts vary, the Philadelphia chromosome is absent, and JAK2 mutations are present in 30 to 50%. But in chronic myelogenous leukemia, red cells are decreased, white cells and platelets are elevated, the Philadelphia chromosome is present, and JAK2 mutations are absent. Now let's move on to a very important distinction, the difference between a leukemoid reaction and chronic myelogenous leukemia. A leukemoid reaction is a reactive neutrophilia, meaning white blood cells rise above 50,000 per cubic millimeter, and this occurs in response to infection or inflammation. In contrast, chronic myelogenous leukemia is a myeloproliferative neoplasm, and it tests positive for the BCR-ABL fusion gene. Now listen carefully to the differences in neutrophil morphology. In a leukemoid reaction, you'll see toxic granulation, dull bodies, and cytoplasmic vacuoles. But in CML, you'll notice the pseudopelger-hued anomaly, where neutrophils have bilobed nuclei. The leukocyte alkaline phosphatase score, or LAP score, is increased in a leukemoid reaction, but it's decreased in chronic myelogenous leukemia, because malignant neutrophils have low enzyme levels. Finally, eosinophils and basophils are normal in a leukemoid reaction, but they are elevated in CML. Now let's talk about polycythemia, which refers to an increase in red blood cell mass, and it comes in different forms depending on the underlying cause. In relative polycythemia, plasma volume is decreased, red blood cell mass remains unchanged, oxygen saturation is unaffected, and erythropoietin levels stay normal. This condition is associated with dehydration and burns, where the apparent rise in red cells is due to reduced plasma. Now listen carefully, in appropriate absolute polycythemia, plasma volume normal, red blood cell mass is increased, oxygen saturation is decreased, and erythropoietin levels are elevated. This is a true increase in RBCs, driven by low oxygen, and it's associated with lung disease, congenital heart disease, high altitude, and obstructive sleep apnea. But in inappropriate absolute polycythemia, plasma volume normal, RBC mass high, oxygen saturation remains normal, yet erythropoietin levels are elevated. This form can be caused by exogenous EPO, such as in athlete misuse, often referred to as blood doping, and also by androgen supplementation. Moreover, malignancies like renal cell carcinoma and hepatocellular carcinoma may secrete erythropoietin inappropriately. Now let's shift to polycythemia vera, where plasma volume is increased, red blood cell mass is markedly increased, oxygen saturation remains normal, but erythropoietin levels are decreased. That's because in polycythemia vera, a primary disturbance causes red cells to rise, and negative feedback suppresses renal erythropoietin production. Now are you ready? Let's talk about chromosomal translocations and their associated disorders. The translocation T814 is seen in Burkitt lymphoma, with c-MYC activation, and you should remember this by the phrase Burk8 lymphoma. The Ig heavy chain genes on chromosome 14 are always active, so when oncogenes like c-MYC or BCL2 get moved next to them, those oncogenes become overexpressed. Moving on, the translocation T1114 is linked to mantle cell lymphoma, which involves cyclin D1 activation. The T1118 translocation is associated with marginal zone lymphoma, while T1418 is seen in follicular lymphoma, which is driven by BCL2 activation. Now listen carefully, the T1517 translocation is found in acute promyelocytic leukemia, which used to be called the M3 type of AML. And don't forget, the T922 translocation, also known as the Philadelphia chromosome, is associated with chronic myelogenous leukemia, and less commonly with acute lymphoblastic leukemia. You can remember it with the mnemonic Philadelphia CRAML cheese, linking it to CML. Now let's dive into Langerhans cell histiocytosis, a collective term for proliferative disorders of Langerhans cells, which are antigen-presenting cells normally found in the skin. This condition typically presents in children, showing up as lytic bone lesions, a skin rash, or recurrent otitis media, often with a mass in the mastoid bone. Now listen carefully, these cells are functionally immature, so they fail to stimulate primary T cells effectively through antigen presentation. On immunohistochemistry, these cells express S100 and CD1A, and under electron microscopy, you'll find Burbeck granules, which appear as tennis rackets or rod-shaped structures, and these are highly characteristic of the disease. Tumor lysis syndrome, now listen carefully. This is an oncologic emergency triggered by massive tumor cell lysis, and it is seen most often with lymphomas and leukemias. Usually, it is caused by treatment initiation, but it can also occur spontaneously, especially with fast-growing cancers. When tumor cells break down, they release potassium, which leads to hyperkalemia. They release phosphate, causing hyperphosphatemia, and this phosphate binds calcium, leading to hypocalcemia due to calcium sequestration. The nucleic acids released during this process break down into uric acid, resulting in hyperuricemia, and this, in turn, can cause acute kidney injury. Prevention and treatment strategies include aggressive hydration, the use of allopurinol, and administration of rasburicase. Tumor cell breakdown leads to an increase in potassium, a reduction in calcium, a rise in uric acid, and an increase in phosphate. Remember this with the phrase, break the cup. Hematology Oncology Pharmacology subsection. Now listen carefully. Heparin works by activating antithrombin, and this results in the reduction of activity primarily of factors 2A, which is thrombin, and factor 10A. It has a short half-life, meaning it doesn't stay in the bloodstream for too long, and its action is quick. Are you following me? That's why, when we talk about its clinical use, it is chosen for immediate anticoagulation, especially in cases like pulmonary embolism, acute coronary syndrome, myocardial infarction, and deep venous thrombosis. Also, it's important to note, it is safe to use during pregnancy because it does not cross the placenta. However, low molecular weight heparin, like enoxaparin, is generally preferred. And don't forget, you must monitor the partial thromboplastin time, or PTT. Now let's talk about adverse effects. Bleeding is one of the most common and serious ones, but thankfully, it can be reversed with protamine sulfate. However, that's not the only concern. Long-term use may lead to osteoporosis, it can cause drug-drug interactions, and even type 4 renal tubular acidosis. And now, here comes something very important, heparin-induced thrombocytopenia, or HIT. There are two types, so listen closely. Type 1 is mild, with platelet counts remaining above 100,000 per mm superscript 3. It's transient, non-immunologic, and usually happens within the first 2 days of administration, and more importantly, it is not clinically significant. But now let's move to HIT type 2, which is much more serious. This involves the development of IgG antibodies against the heparin-bound platelet factor 4, or PF4, and this usually happens between 5 to 10 days after heparin use begins. These antibody, heparin, PF4 complexes bind and activate platelets, leading to their removal by splenic macrophages, and this causes both thrombosis and a reduced platelet count. This form of HIT carries the highest risk when unfractionated heparin is used. So, the treatment is to discontinue heparin immediately, and start an alternative anticoagulant like argatroban. And here's a useful tip, fondaparinux is considered safe in these cases, because it does not interact with PF4. Now let's talk about some important notes to remember. Low molecular weight heparins, such as enoxaparin and dalteparin, act mainly on factor 10A and they have a longer half-life than unfractionated heparin. Fondaparinux, by contrast, acts only on factor 10A. But both of them, that is low molecular weight heparins and fondaparinux, are not easily reversible. Finally, when a patient has renal insufficiency, unfractionated heparin is preferred because low molecular weight heparins are cleared through the kidneys and should be used with caution. Now let's talk about warfarin, which works by inhibiting vitamin K epoxide reductase, through competition with vitamin K, leading to inhibition of vitamin K-dependent gamma carboxylation of clotting factors 2, 7, 9, and 10, as well as proteins C and S. Its metabolism is affected by polymorphisms in the gene for vitamin K epoxide reductase complex, also known as VCORC1. In laboratory assays, warfarin affects the extrinsic pathway, and it increases PT. It also has a long half-life, and there's a helpful mnemonic to remember it: the ex-president went to warfarin. Now listen carefully. Warfarin is used for chronic anticoagulation, such as in venous thromboembolism prophylaxis and for the prevention of stroke in patients with atrial fibrillation. However, it is not used in pregnant patients, because unlike heparin, warfarin crosses the placenta. PT and INR should be monitored closely during its use, and its effects are significant and prolonged. Are you following me? The adverse effects of warfarin include bleeding, teratogenic effects, and skin or tissue necrosis, along with drug-drug interactions, as it is metabolized by cytochrome P450, specifically CYP2C9. There is also an initial risk of hypercoagulation because protein C has a shorter half-life than factors 2 and 10. This means that existing protein C depletes before factors 2 and 10 do, and before warfarin can reduce their production, which leads to a temporary hypercoagulable state. Now let's talk more about this. The skin and tissue necrosis that occurs within the first few days of large warfarin doses is believed to be due to small vessel microthrombosis. That's why heparin bridging is often used when starting warfarin. Heparin activates antithrombin, which provides anticoagulation during this early, transient hypercoagulable phase caused by warfarin. So initial heparin therapy lowers the risk of recurrent venous thromboembolism and skin or tissue necrosis during the transition. You should remember this: for reversal of warfarin, vitamin K is given. And if rapid reversal is needed, then fresh frozen plasma, or FFP, or prothrombin complex concentrate, PCC, is used. Now let's compare heparin and warfarin. Heparin is administered parenterally, either intravenously or subcutaneously, while warfarin is given orally. Heparin acts in the blood, but warfarin acts in the liver. Heparin has a rapid onset, within seconds, but warfarin acts slowly, limited by the half-lives of normal clotting factors. Now listen carefully to this comparison. The duration of action for heparin is in hours, but for warfarin, it lasts for days. Monitoring differs too, with heparin monitored by PTT, reflecting the intrinsic pathway, and warfarin monitored by PT and INR, reflecting the extrinsic pathway. Heparin does not cross the placenta, making it safe for pregnancy, but warfarin does cross the placenta and is teratogenic. Now let's shift to direct coagulation factor inhibitors, which do not usually require lab monitoring. Bivalirudin, argatroban, and dabigatran directly inhibit thrombin, also known as factor 2A. They are used for venous thromboembolism and atrial fibrillation, and can be used in HIT, that is, heparin-induced thrombocytopenia, when heparin is bad for the patient. The main adverse effect is bleeding, and for dabigatran, idarucizumab can be used as an antidote. Finally, apixaban, edoxaban, and rivaroxaban directly inhibit, or ban, factor 10A. These are oral agents used for treatment and prophylaxis of deep vein thrombosis and pulmonary embolism, and also for stroke prophylaxis in patients with atrial fibrillation. Bleeding is the primary adverse effect, and reversal is possible with andexanet alpha. Now let's talk about anticoagulation reversal, which is crucial when bleeding occurs or urgent surgery is needed. For heparin, the reversal agent is protamine sulfate, which is a positively charged peptide that binds to the negatively charged heparin, neutralizing its effect. For warfarin, vitamin K is used, although it acts slowly. For more rapid reversal, fresh frozen plasma, FFP, or prothrombin complex concentrate, PCC, can be given alongside vitamin K to quickly restore clotting function. Now listen carefully. For dabigatran, the reversal agent is idarucizumab, which consists of monoclonal antibody Fab fragments that bind directly to dabigatran and neutralize its activity. When it comes to direct factor 10A inhibitors, such as apixaban or rivaroxaban, the reversal agent used is andexanet alpha, a recombinant modified factor 10A molecule that is inactive, but acts as a decoy to bind and neutralize the drugs. This makes reversal specific and targeted for patients on these anticoagulants. Now let's shift gears to antiplatelet drugs, which all work by reducing platelet aggregation. First, we have aspirin, which irreversibly blocks cyclooxygenase, also called COX, leading to reduced thromboxane A2 release. It is used in acute coronary syndrome, during coronary stenting, and to reduce the incidence or recurrence of thrombotic stroke. But you should remember, aspirin has notable adverse effects, including gastric ulcers, tinnitus, allergic reactions, renal injury, and in children, Reye syndrome. Are you following me? Next are the ADP receptor blockers, clopidogrel, prasugrel, and ticagrelor, which block the P2Y12 receptor, reducing ADP-induced expression of glycoprotein 2B/3A. These are used similarly to aspirin and are commonly part of dual antiplatelet therapy. The main adverse effect, unsurprisingly, is bleeding, and careful monitoring is required during combined therapy, especially after cardiac interventions. Now let's talk about the glycoprotein 2B/3A inhibitors, including eptifibatide, tirofiban, and ipsiximab, which block the fibrinogen receptor on activated platelets. These are used in cases of unstable angina and during percutaneous coronary intervention, where preventing clot formation is critical. But like others, they can cause bleeding, and additionally, thrombocytopenia may occur as an adverse effect, making platelet count monitoring essential. Now listen carefully, cilostazol and dipyridamole work differently. They block phosphodiesterase, which reduces cyclic AMP hydrolysis and increases cyclic AMP levels in platelets. This action inhibits platelet aggregation and has multiple clinical uses. These include intermittent claudication, stroke prevention, cardiac stress testing, and preventing coronary stent restenosis. Their adverse effects include nausea, headache, facial flushing, hypotension, and abdominal pain, which patients should be warned about. Finally, let's talk about thrombolytics, including alteplase, also known as TPA, retiplase, RPA, and tenecteplase, TNK-TPA. These agents aid directly or indirectly in converting plasminogen to plasmin, which cleaves fibrin clots and dissolves thrombi. They increase PT and PTT, but do not affect platelet count. Clinically, they are used in early myocardial infarction, early ischemic stroke, and for direct thrombolysis of high-risk pulmonary embolism. You should remember this: the primary adverse effect of thrombolytics is bleeding. They are contraindicated in patients with active bleeding, a history of intracranial bleeding, recent surgery, bleeding disorders, or severe hypertension. If reversal is needed, it is nonspecific, involving antifibrinolytics such as aminocaproic acid or tranexamic acid, platelet transfusions, and factor corrections, including cryoprecipitate, fresh frozen plasma, and PCC. Now let's talk about cancer therapy and how it aligns with the phases of the cell cycle. Some drugs act during specific phases, while others are cell cycle independent. Let's begin with microtubule inhibitors, which disrupt mitosis. Taxanes prevent microtubule disassembly, freezing the mitotic spindle, while vinca alkaloids block microtubule formation altogether, stopping mitosis from even beginning. These agents specifically target the M phase, where cells are actively dividing, and cytokinesis is occurring. Now listen carefully, there are also drugs that do not depend on the cell cycle phase. These are the cell cycle independent agents, including platinum compounds and alkylating agents, as well as busulfan, nitrogen mustards, nitrosoureas, and procarbazine. Additionally, dactinomycin acts by DNA intercalation, slipping between DNA base pairs to prevent transcription. These drugs can target both rapidly dividing and resting cells, since their mechanism does not rely on any specific cell cycle phase. Are you following me? As cells move through the interphase, they enter various stages, starting with the resting phase, or G0, then G1, where the cell grows and prepares for DNA synthesis, followed by the S phase where DNA is actually synthesized. After that comes G2, where the cell performs DNA repair and checks for errors before entering the M phase to undergo mitosis and divide. Bleomycin works in the G2 phase by causing DNA strand scission, and anthracyclines act throughout the cycle by intercalating into DNA. Now let's go deeper. The S phase is the site of DNA synthesis, and here we find antimetabolites at work. These include cladribine, cytarabine, 5-fluorouracil, hydroxyurea, methotrexate, pentostatin, and thiopurines. All of these drugs target nucleotide synthesis and DNA replication. Of note, cladribine is cell cycle phase nonspecific, meaning it works outside of strict S phase boundaries. These drugs interrupt the building blocks of DNA, crippling the cell's ability to duplicate its genome. Now let's talk about topoisomerase inhibitors, which interfere with enzymes that relieve torsional strain during DNA replication. Adiposide and tenopside inhibit topoisomerase II, leading to double-strand DNA breaks, while irinotecan and topotecan inhibit topoisomerase I, causing single-strand breaks. These mechanisms stall DNA replication and trigger apoptosis in rapidly dividing cancer cells, particularly during the S and G2 phases of the cell cycle. You should remember this: key regulatory proteins, Rb and p53, modulate the G1 restriction point, acting as checkpoints to prevent the cell from progressing if there is DNA damage. When these regulators are defective, cells may replicate uncontrollably. And this is where cancer therapy becomes even more targeted. By hitting specific pathways, drugs can restore the control lost through mutations in these checkpoints. Now listen carefully, here's how cancer therapies target different cellular processes. Methotrexate and 5-fluorouracil reduce thymidine synthesis, impairing DNA replication. Thiopurines lower de novo purine synthesis, while hydroxyurea blocks ribonucleotide reductase, preventing ribonucleotide conversion to deoxyribonucleotide. Alkylating agents and platinum compounds cross-link DNA, making it unreadable. Bleomycin causes DNA strand breakage, and anthracyclines, along with dactinomycin, intercalate into DNA. Adiposide and tenopside inhibit topoisomerase II, and irinotecan with topotecan inhibit topoisomerase I. And finally, let's talk about cellular division inhibitors. Vinca alkaloids block microtubule formation, while taxanes prevent microtubule disassembly, both freezing mitosis in place. These mechanisms ensure that cancer cells cannot complete division, leading to apoptosis and tumor regression. Now, shifting focus slightly, let's look at antibody-drug conjugates, an exciting class of therapies that combine precision with potency. Are you ready for this? These conjugates are formed by linking monoclonal antibodies to cytotoxic chemotherapy drugs. The antibody binds to a tumor-specific antigen and, through receptor-mediated endocytosis, is taken into the cancer cell. Inside lysosomes, the drug is released and induces cytotoxicity, sparing normal cells and increasing efficacy while reducing toxicity. One well-known example is adutrastuzumab emtansine, or T-DM1, used in HER2-positive breast cancer. Now let's talk about anti-tumor antibiotics. Among them, dactinomycin is cell cycle nonspecific, but bleomycin and anthracyclines, including doxorubicin and daunorubicin, are more selective, acting specifically during the G2 and M phases of the cell cycle. Let's begin with bleomycin, which generates free radicals, leading to DNA strand breaks. It is especially useful for treating testicular cancer and Hodgkin lymphoma. However, you should remember that its adverse effects include pulmonary fibrosis, a serious and potentially irreversible condition, and skin hyperpigmentation. Are you following me? Moving on to dactinomycin, also known as actinomycin D, this drug intercalates into DNA, blocking RNA synthesis. It is used for pediatric cancers like Wilms tumor, Ewing sarcoma, and rhabdomyosarcoma. The primary side effect is myelosuppression. Now let's talk about the anthracyclines, which include doxorubicin and daunorubicin. These drugs generate free radicals, intercalate into DNA, cause DNA strand breaks, and inhibit topoisomerase II, all of which disrupt DNA replication. They are widely used in solid tumors, leukemias, and lymphomas. However, their most feared side effect is dilated cardiomyopathy, which is often irreversible. This can be prevented by dexrazoxane, a cardioprotective agent. They also cause myelosuppression. Now shifting gears, let's move into antimetabolites, which are mostly S-phase specific, except for cladribine, which works across all cell cycle phases. Let's begin with the thiopurines, including azathioprine and 6-mercaptopurine. These are purine analogues that reduce de novo purine synthesis. Azathioprine is converted into 6-mercaptopurine and activated by HGPRT. Clinically, they're used in rheumatoid arthritis, IBD, SLE, ALL, steroid refractory conditions, organ rejection prevention, and glucocorticoid weaning. Adverse effects include myelosuppression, GI, and liver toxicity, and remember, 6-MP is inactivated by thiopurine S-methyltransferase and xanthine oxidase, so toxicity increases with allopurinol or febuxostat. Now listen carefully. Cladribine and pentostatin are purine nucleoside analogues that cannot be processed by adenosine deaminase, interfering with DNA synthesis. These are used for hairy cell leukemia, and their main adverse effect is myelosuppression, which again highlights the importance of blood count monitoring during therapy. Next, we have cytarabine, also called arabinofuranosyl cytidine, which is a pyrimidine nucleoside analog. It works by causing DNA chain termination and inhibiting DNA polymerase, making it useful in AML and lymphomas. Its toxicity also includes myelosuppression, which can be dose-limiting. Now let's talk about 5-fluorouracil, or 5-FU, which is a pyrimidine analog bioactivated to 5-FDUMP, inhibiting thymidylate synthase, and thus reducing DTMP and DNA synthesis. Its prodrug form is capecitabine, used in colon cancer, pancreatic cancer, actinic keratosis, and basal cell carcinoma, topically. When combined with leucovorin, the effects are enhanced. Side effects include myelosuppression and palmar-plantar erythrodysesthesia, also called hand-foot syndrome. Now let's not forget hydroxyurea, which inhibits ribonucleotide reductase, decreasing DNA synthesis. It's useful in myeloproliferative disorders like CML and polycythemia vera, and in sickle cell disease, where it raises fetal hemoglobin levels. However, it can cause severe myelosuppression and megaloblastic anemia, which require regular lab monitoring. Finally, let's discuss methotrexate, a folic acid analog that competitively inhibits dihydrofolate reductase, leading to decreased DTMP and impaired DNA synthesis. In cancers, it's used for ALL, lymphomas, choriocarcinoma, and sarcomas. In non-cancer conditions, it's used for ectopic pregnancy, medical abortion with misoprostol, rheumatoid arthritis, psoriasis, IBD, and vasculitis. Its adverse effects include myelosuppression, reversible with leucovorin, along with hepatotoxicity, mucositis, pulmonary fibrosis, folate deficiency, which is teratogenic, and nephrotoxicity. Now let's talk about alkylating agents, a group of chemotherapy drugs that are cell cycle nonspecific, meaning they can attack cancer cells at any stage of division. Starting with busulfan, which works by cross-linking DNA, this drug is primarily used to ablate the patient's bone marrow prior to bone marrow transplantation. Almost all patients experience severe myelosuppression, and additional risks include pulmonary fibrosis and hyperpigmentation, which makes supportive care and careful monitoring crucial during treatment. Now listen carefully. Next are the nitrogen mustards, which include cyclophosphamide and ifosfamide. These drugs cross-link DNA and require bioactivation by the liver to become effective. They are used in solid tumors, leukemias, lymphomas, and even rheumatic diseases such as SLE and granulomatosis with polyangiitis. Their adverse effects include myelosuppression, SIAD, and Fanconi syndrome, especially with ifosfamide. They also cause hemorrhagic cystitis and bladder cancer, but this can be prevented with mesna, a uroprotective agent. Now let's discuss the nitrosoureas, which include carmustine and lomustine. Like others, they cross-link DNA and require liver bioactivation, but what makes them special is their ability to cross the blood-brain barrier, allowing CNS entry. They are ideal for treating brain tumors, including glioblastoma multiforme. The phrase, "put nitro in your Mustang and travel the globe," helps you remember their CNS activity. However, they come with CNS toxicity, causing convulsions, dizziness, and ataxia. Now listen closely. Procarbazine is a bit of a mystery in terms of its exact mechanism, though it is known to be a weak MAO inhibitor, which raises the risk of hypertensive crisis with tyramine ingestion. It's used for Hodgkin lymphoma and brain tumors, but can cause myelosuppression, pulmonary toxicity, leukemia, and even a disulfiram-like reaction, especially when alcohol is involved. Now let's shift into the class of platinum compounds, which include cisplatin, carboplatin, and oxaliplatin. These are also cell cycle nonspecific, and they cross-link DNA, leading to cell death. They are used in solid tumors, like testicular, bladder, ovarian, GI, and lung cancers, and also in lymphomas. But be careful, adverse effects include nephrotoxicity, particularly Fanconi syndrome, which can be prevented using amifostine, along with peripheral neuropathy and ototoxicity, all of which can be dose-limiting. Are you following me? Now let's dive into the microtubule inhibitors, which are all M-phase specific and block the ability of cells to divide by interfering with microtubule dynamics. This includes two main groups, the taxanes and the vinca alkaloids, each acting at different points in the microtubule cycle and causing distinct adverse effects. Let's begin with the taxanes, such as docetaxel and paclitaxel. These drugs hyperstabilize polymerized microtubules, preventing the mitotic spindle from breaking down, which is crucial for proper cell division. They are used in various cancers, especially ovarian and breast carcinomas. Their toxicities include myelosuppression, neuropathy, and hypersensitivity reactions, which may require premedication. And remember this, taxes stabilize society, just like taxanes stabilize microtubules. Now let's go to the vinca alkaloids, including vincristine and vinblastine, which bind to beta-tubulin and inhibit its polymerization, preventing the formation of the mitotic spindle. They are effective against solid tumors, leukemias, and both Hodgkin and non-Hodgkin lymphomas. But be careful, vincristine crisps the nerves, causing neurotoxicity, axonal neuropathy, and constipation, even ileus. On the other hand, vinblastine blasts the marrow, leading to myelosuppression. Now listen carefully, let's finish with the topoisomerase inhibitors, which all increase DNA strand breaks, causing cell cycle arrest in the S and G2 phases. There are two groups here, the tecans, which inhibit topoisomerase I, and the hpasides, which inhibit topoisomerase II. Each group has distinct clinical uses and toxicities to watch out for. Starting with irinotecan and topotecan, these inhibit topoisomerase I, which prevents the repair of single-strand DNA breaks. You'll remember them by the tecan ending. They're used for colon, ovarian, and small cell lung cancer, and they can cause severe myelosuppression and diarrhea, both of which can be life-threatening if not managed properly. Now lastly, we have etoposide and tenopicide, which inhibit topoisomerase II, leading to double-strand DNA breaks and apoptosis. Think of their names, both side for topo II. These are used in testicular cancer, small cell lung cancer, leukemia, and lymphoma. Their toxicities include myelosuppression and alopecia, both of which are common in rapidly dividing tissues. Now let's begin with tamoxifen, a selective estrogen receptor modulator with a complex mode of action, and you should remember this, it acts as an antagonist in breast tissue, a partial agonist in the endometrium, and also in the bone. It works by blocking the binding of estrogen to estrogen receptors in ER-positive cells, making it an essential treatment for hormone-sensitive cancers. Clinically, it is used both for the prevention and treatment of breast cancer, and also for the prevention of gynecomastia in patients who are undergoing prostate cancer therapy, where estrogen suppression is needed to counteract hormonal imbalance. Now listen carefully, because the adverse effects of tamoxifen include hot flashes, and an increased risk of thromboembolic events, such as deep vein thrombosis and pulmonary embolism, which can be dangerous and require careful risk assessment. In addition, because of its partial agonist effect in the endometrium, it also increases the risk of endometrial cancer and even uterine sarcoma, which must be monitored with long-term use, especially in postmenopausal women. Now let's talk about the powerful class of anti-cancer monoclonal antibodies, which are engineered proteins designed to recognize specific targets on cancer cells. They work against extracellular targets, either by neutralizing the target directly, or by promoting immune system recognition, including antibody-dependent cellular cytotoxicity, or ADCC, mediated by natural killer cells. These agents are eliminated by macrophages, and notably, they are not cleared by the kidneys or liver, making them useful even in patients with organ dysfunction. Are you ready to go deeper? Let's explore the specific monoclonal agents and their targets. Alemtuzumab targets CD52 and is used for chronic lymphocytic leukemia, also known as CLL, and multiple sclerosis. However, it significantly increases the risk of infections and autoimmunity, including conditions like idiopathic thrombocytopenic purpura, or ITP, so immune monitoring is essential. Next up is bevacizumab, which targets VEGF, a factor involved in blood vessel formation. This agent is useful in colorectal cancer, renal cell carcinoma, non-small cell lung cancer, and even angioproliferative retinopathy. But it comes with risks, namely hemorrhage, blood clots, and impaired wound healing, due to its inhibition of vascular growth, which is also vital for tissue repair. Now listen carefully. Cetuximab and panitumumab both target EGFR, and are indicated for metastatic colorectal cancer, but only in those with wild-type RAS, and also for head and neck cancer. They can cause a rash, elevated liver function tests, and diarrhea, so liver monitoring and supportive care are important during therapy. Let's move on to rituximab, which binds CD20, a marker found on B cells, and is used in a wide range of diseases, from non-Hodgkin lymphoma and CLL, to rheumatoid arthritis, ITP, TTP, autoimmune hemolytic anemia, and multiple sclerosis. The most notable adverse effect is the infusion reaction, which results from cytokine release when rituximab interacts with its target on B cells, often requiring premedication or slower infusion rates. Now let's talk about trastuzumab, which targets HER2, and here's a memory aid: don't trust her, she will break your heart. This agent is used in breast cancer and gastric cancer, especially in tumors that overexpress HER2. But it can cause dilated cardiomyopathy, a potentially serious side effect that is often reversible, making cardiac monitoring essential during treatment. And now, you should remember this: pembrolizumab, nivolumab, and semiplimab target PD-1, a checkpoint on T cells. These drugs are used in various cancers, including non-small cell lung cancer, renal cell carcinoma, melanoma, and urothelial carcinoma. However, they increase the risk of autoimmunity, including dermatitis, enterocolitis, hepatitis, pneumonitis, and endocrinopathies, which may require immunosuppressive therapy to manage. Finally, let's end this section with agents that target PD-L1, such as atezolizumab, durvalumab, and avelumab, and also ipilimumab, which target CTLA-4. Now let's talk about anti-cancer small molecule inhibitors, a powerful class of drugs designed to block specific molecular targets inside cancer cells, disrupting their growth, division, and survival. We begin with alectinib and crizotinib, which target ALK, and are primarily used in non-small cell lung cancer. These drugs may cause edema, rash, and diarrhea. Next, we move to EGFR inhibitors, including erlotinib, gefitinib, and afatinib, which are also used in non-small cell lung cancer. Their side effects include a characteristic rash and diarrhea. Now listen carefully: imatinib, dasatinib, and nilotinib all target BCR-ABL, the fusion protein, and they also affect other tyrosine kinases like CKIT, making them useful in CML, ALL, and gastrointestinal stromal tumors, or GISTs. Their adverse effects include myelosuppression, elevated liver function tests, edema, and muscle pain. Are you following me? Let's move to ruxolitinib, which targets JAK1/2, and is used in polycythemia vera, a myeloproliferative disorder. It may cause bruising and elevated liver enzymes. Now let's talk about proteasome inhibitors, including bortezomib, ixazomib, and carfilzomib, which work by inducing cell cycle arrest at the G2/M phase through the accumulation of abnormal proteins, leading to apoptosis. These agents are especially important in multiple myeloma and mantle cell lymphoma, but they may cause peripheral neuropathy and herpes zoster reactivation, due to reduced T-cell activation and impaired cell-mediated immunity. Now listen carefully: vemurafenib, encorafenib, and dabrafenib are inhibitors of BRAF, and are particularly useful in treating melanoma, often in combination with MEK inhibitors, like trametinib. These agents commonly cause rash, fatigue, nausea, and diarrhea. Next is palbociclib, which targets cyclin-dependent kinase 4 and 6, inducing cell cycle arrest at the G1/S transition, ultimately leading to apoptosis. It is used in breast cancer, and may result in myelosuppression and pneumonitis. Are you ready for more? Let's move to olaparib, a PARP inhibitor, short for poly-A-D-pyribose polymerase, which plays a role in DNA repair. This drug is effective in breast, ovarian, pancreatic, and prostate cancers, especially those with BRCA mutations. Side effects include myelosuppression, edema, and diarrhea. Now let's shift gears and discuss chemotoxicity amelioration, the protective agents used to reduce or counteract the side effects of chemotherapy. First, we have amifostine, a free radical scavenger, which is used to prevent nephrotoxicity from platinum compounds, like cisplatin. Next is dexrazoxane, an iron chelator, that prevents cardiotoxicity caused by anthracyclines, such as doxorubicin. Now listen carefully. Leucovorin, also known as folinic acid, is a tetrahydrofolate precursor, used for myelosuppression rescue during methotrexate therapy, and it also enhances the effects of 5-fluorouracil. Let's move on to mesna, a sulfhydryl compound that binds to acrolein, a toxic metabolite of cyclophosphamide and ifosfamide, preventing hemorrhagic cystitis. Now let's talk about rasburicase, a recombinant uricase enzyme, which catalyzes the conversion of uric acid to allantoin, a more soluble and easily excretable form, making it essential in managing tumor lysis syndrome. And for chemotherapy-induced nausea and vomiting, we have several options: ondansetron and granisetron, which are 5-HT3 receptor antagonists, are used to manage acute nausea and vomiting, usually occurring within the first 1 to 2 hours after chemotherapy. In addition, prochlorperazine and metoclopramide are dopamine D2 receptor antagonists, also effective in controlling acute emesis. And for delayed nausea and vomiting, occurring more than 24 hours after chemotherapy, aprepitant and fosaprepitant, which are NK1 receptor antagonists. Lastly, let's not forget filgrastim and sargramostim, which are recombinant granulocyte and macrophage colony-stimulating factors, used to prevent or treat neutropenia. And finally, epoetin alpha, a recombinant erythropoietin, is used to treat anemia. Now let's talk about key chemotoxicities, and listen carefully, because this part is essential to remember. Cisplatin and carboplatin, they cause ototoxicity. Vincristine, on the other hand, is known for causing peripheral neuropathy, while bleomycin and busulfan can result in pulmonary fibrosis, and that's something you need to keep in mind. Doxorubicin and daunorubicin, both of these are associated with cardiotoxicity, and so is trastuzumab, which also carries a risk for the heart. Finally, cisplatin and carboplatin again, but this time they bring nephrotoxicity, affecting the kidneys, while cyclophosphamide leads to hemorrhagic cystitis, and you should remember this. Nonspecific, but very common toxicities of nearly all cytotoxic chemotherapies include myelosuppression, that means neutropenia, anemia, and thrombocytopenia, along with GI toxicity, which shows up as nausea, vomiting, and mucositis, and don't forget, alopecia is also included, and that wraps up the key chemotoxicities you must be familiar with.